Welcome,
Hello.
Dr. Amrita.
I'm
Hello.
fine. Hello,
Sir,
Namaste, ma'am. Hi, Dr. Monica.
Hello, Amrita ma'am.
Hello,
Good
hi.
evening, Nandita. Good evening, Mahesh
hi,
sir.
this is support team.
Good.
We are going live in 3, 2, 1. We are live now.
Hello, myself Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas, I welcome you all for this Perfection Series, Season 12, today on 12th of March 2024. The topic is fertility preservation. Before starting the webinar, we would like to have a lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
It's my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine at Bhopal Fertility and Endoscopy Center. She is also professor at Allen Medical College, Bhopal. She is managing committee member ISAR. She is West Zone coordinator Medical Disorders Committee FOXY, and she is convener of ISAR Perfection Series and convener of FOXY Symbiosis Series. Over to you, madam.
Good evening, everyone. On the 12th of March at 1600 hours, we start our Perfection 12, and this is on fertility preservation, a topic which is very much in vogue as well as very important because not only is fertility preservation relevant to each and every practicing IVF practitioner nowadays, but also it is something which we will face day in and out because more and more children and adolescents with cancers, they are having better survival because of advanced treatment. This better survival means that they will probably live through their early and mid reproductive span, probably to a well advanced age in the fourth and the fifth decades of life. And there they've already been subjected to chemotherapy, radiotherapy, which have been gonadotoxic. The concern is that in pre-pubertal children, we don't have the option of freezing gametes. So we have to freeze tissue. And in post-pubertal children, that is the adolescents, we have to stimulate their gonads in order to get the sperms and the oocytes for freezing. Tissue freezing is troublesome in the sense that you might not get, after thawing, viable tissue which is able to produce gametes. And even oocyte cryopreservation is not very perfect till now. So in order to unravel all these mysteries, and there is another sector that is the non-oncological conditions which are causing fertility issues like autoimmune diseases. We have Turner syndrome, we have SLE, we have, lymphomas, we have aplastic anemias. These also cause a rapid decline in fertility. Then there's a huge population which is transgenders, which have got legal rights nowadays. So these transgender patients also want to expand their family, want their fertility to be, they want to have a child. So that these are all the issues which are going to be discussed by a galaxy of speakers. So we are going from clinical aspects to technical aspects. Then we have a wonderful young speaker who just was awarded the Yuva Orator for her topic on fertility preservation. So we hunted her down and we called her to this webinar. And we have a wonderful panel by Gopinath sir. And not to forget Dr. Asha Bakshi, who will be talking on, fertility preservation in adolescents. So before I begin this webinar, I would like to pay gratitude and thanks to the dignitaries of ISAR. And Dr. Manisha, you will be telling me if anybody joins so that we can acknowledge their presence there and then. Yes. So our welcome of dignitaries begins with our patron, Dr. Nandita Palshetkar, immediate past president ISAR. Madam is the driving force behind the inauguration and continuation of Perfection series in collaboration with ISAR. Next slide, please. I would like to welcome our president and thank him profusely for continuing with ISAR Perfection series. He took over as president in ISAR Bhubaneswar in February, and he has been very large-hearted in continuing our series with the same enthusiasm, with even more support. Now we have got Dr. Pratik Tambe with us as program coordinator. We have got Dr. Fessy Louis, and sir is a great academician. We can see him, a visiting consultant in so many hospitals, been very active all over in MSR, RCOG, MOGS, and of course, he's going to steer ISAR to greater and greater heights during his tenure. Welcome, sir. I would like to invite as our Honorary Secretary General ISAR, Dr. Asha Anil Bakshi, and she is also a speaker today. Madam is not only a brilliant star in the horizon of ISAR in Madhya Pradesh, but all over India. At present, she holds the post of Secretary General of ISAR, and she is very also active in RCOG, IAG, of course, MP ISAR, and she's also heading the PCPNDT Indore committee as an advisory member so that she can keep all our members out of trouble. She has received so many awards. She has got many firsts to her credit in the state of MP, and she is a great conference organizer. We thank you, Asha ma'am, for being with us today. Dr. Charu Joshi is our chairman embryology, and he is a postgraduate and doctorate in life sciences. He's running a very successful bank of, gametes and ART bank in Indore that is called the Genes India ART Bank. And he is a very, very senior and highly respected embryologist of our country. Dr. Randhir Singh is the managing committee member of ISAR, the governing council member of ICRM, which was awarded to him recently, and he is very active in supporting us in all our academic ventures. Next, I would like to welcome and say thanks to Dr. Fessy Louis, who is our program coordinator, very senior IVF specialist of India. We look up to him all the time for help and advice. He is heading Amrita Institute of Medical Sciences, has been the FOXI Vice President of the South Zone. He's ISAR Managing Committee member and very active all over in Kerala in various bodies. We welcome Dr. Fessy Louis. Dr. Pratik is amongst us, and he's always there in every program of Perfection. He was in the inaugural Perfection. We invited Dr. Pratik because we wanted him to have that, dynamic presence when Perfection started. And of course, you can see from his CV slide, he is a very able IVF specialist, endoscopic surgeon, embryologist, and is present in almost all the important bodies related to IVF in India as well as Maharashtra, has been the recipient of so many awards and is a very knowledgeable IVF specialist of India. We look up to him all the time. So since I think out of all the dignitaries, only Dr. Pratik is there, Dr. Purnima?
Yes, ma'am. Yes, ma'am.
So, Dr. Pratik, will invite you to please bless us with your words of wisdom.
Thank you, Dr. Monica and Dr. Randhir Singh, for inviting me to be one of the coordinators for this very beautiful ISAR Perfection series. I think this was something which was the need of the hour, where all academicians needed a platform. There are a lot of, not only amongst laypersons, but also amongst clinicians who are aspiring to reproductive medicine practice. And with your entire series, with all the stalwarts that you have as faculty, I'm sure you'll go a long way towards dispelling these myths and spreading the light of knowledge throughout the country. Thank you again for having me, and I wish you and Randhir all the very best for the future.
Thank you. Thank you, Dr. Pratik. And Dr. Asha
Thank you,
Bakshi
Dr. Pratik. Yes.
amongst us. Our Honorary Secretary General has joined. Madam, we have introduced your CV, and there is actually no need of introduction for Asha ma'am. She's so well known. But still, we would like to have a few words from her before we begin our program as blessings from our mentor.
Thank you, Monica.
for inviting me. And it's really, your series is going on very well. And I'm sure it is benefiting a lot of people. And even I'm sending this to all my ICOG reproductive medicine certificate and this thing candidates also who have joined me. So it is being helpful for everyone, and keep doing the good work. And very important that ISA should really do such activities so that more and more people get interested, and they become the members of the society and spread the knowledge everywhere. Thank you.
Yes, thank you, ma'am.
Thank you,
And
ma'am. Thank you, ma'am.
that's right, because I think Manisha, Purnima, and myself, we are getting almost one request daily for ISAR membership. So we are very happy that this series is making a difference and making people, and we can involve juniors in a comprehensive manner.
Yeah, true.
So thank you, Asha ma'am. And now I would like to, without any further delay, Dr. Alpesh Gandhi has joined us. He is our chief guest for today. Dr. Alpesh Gandhi, when he visited, he came across as a very dynamic Foxy president. And the way he speaks, it captures the audience. He took over as Foxy president during COVID time, but still he kept that, flame alive. We started dealing with academics online, all thanks to his vision and his dynamism. And he also utilized that depressing period of all over the world with guidelines. So he came up with these GCPRs on pregnancy with COVID-19. And his book on high-risk pregnancy is famous all over the world, been translated in so many languages. Sir has been very active in, preparing guidelines, not only for COVID, but also obstetric HDU, ICU. Government of India takes help from him. He's also been active in the Foxy Gestosis GCPRs and optimizing the cesarean section rates. We are so blessed to have you. One of his most successful achievements has been the AICOG 2017 in Ahmedabad, which we all thoroughly enjoyed. And every time he speaks, we want to note few points down in order to enhance our practice. Alpesh sir, we are so blessed to have you, and we would like to have your chief guest address. Sir, you're muted, sir.
Thank you very much, Dr. Monica, for the invitation as well as kind introduction, appreciating the work done for Foxy as the President Foxy. And it was possible because of the support from all of you across India. I would like to, first of all, at the beginning, I would like to congratulate the newly elected team of ISAR, my very good friend, Dr. Amit, Dr. Asa, and all the office bearers and managing committee member of ISAR. I would also like to congratulate Dr. Monica, Dr. Ranveer, and all the organizers for this very meaningful, very interesting series. I've also heard many times about the series, and it is very popular. I know I have many friends. We are regularly attending this series. So I would definitely, I'm so happy, and I would like to congratulate you for continuing this series. Of course, in India, incidence of infertility is very high as per WHO, somewhere between, it is say 4 to 16% in different parts, and infertility is definitely growing year by year in India. And many other conditions like endometriosis are also and also elusive challenge. So many problems we are facing in day-to-day practice also. And infertility today has become an entire field of super specialism because of all of you experts in itself, from the semen analysis right up to PGD. It is essential for each one of us to know how an infertile patient is to be managed and which are the good options for that particular couple. And as just discussed few minutes before, people having some medical diseases, autoimmune disorders, cancers, some surgical procedures, undergone some surgical procedures, some adolescent problems, accidents, which adversely affected their fertility might opt for a fertility preservation option. And today's this series episode is exclusively dedicated for this fertility preservation. So this is very, very important, and it's good that it's a very focused. Today we have a very focused topic to be discussed, and of course, nothing to say. Cryopreservation of embryo and oocytes is recommended as a fertility preservation option before undergoing chemotherapy and so many other conditions. I'm sure we all are going to discuss thoroughly about all these aspects of these aspects of fertility preservation. On a lighter side, a very lighter side, I know it may not be the topic of discussion, and it is not also related to this particular focus topic of fertility preservation. Just on a lighter side, I would also like to say, in this modern time of technology, we should also not forget to counsel with our patient about the natural ways of fertility preservations, like eating good food, to stop smoking, drugs, alcohol, to do regular exercise and other things. We have invited so many national experts, authorities of the subject today, and I am sure it is going to be one of the best webinars of the recent time. My best wishes to the organizers and all my friends. I can see so many friends. Today's guest of honor, Dr. Sampath Kumari, Dr. Mahesh, my friend Fesi, Pratik, so many friends are there. My high regards and hello to all of you, and my best wishes to the organizers, and I wish happy learning to all the delegates. Thank you very much once again for inviting me and giving this honor. Thank you.
Thank
Thank you, Alpesh sir. Being a past president of Foxy and you have handled the COVID time, sir, just I'll take few seconds. Yesterday we were meeting with the National Association members, IMA and all. So Supreme Court has given the capping of the rates. So we are all united, and before 6th we are presenting. So we'll be needing your inputs as a national past president, sir. Thank you, sir.
Sure. Thank you. Thank you.
Thank you, Alpesh sir, for the kind words. And you have not only spoken about your vision of Foxy, but also extended it to ISAR and included it so nicely that basically, I think ma'am will also agree, Madhuri ma'am will also agree, basically ISAR and Foxy are intertwined. They are not mutually exclusive. They are very much, it's an umbrella which covers everything. So we are so happy that we always, pay high regards to all senior Foxians as well as Isarians in Perfection series.
I think we all are under one umbrella, and definitely we should respect each organization and we should do joint work. So
Yes.
Foxy, it's a basically more responsibility, I would say, of Foxy to take care of all these organizations.
Thank you.
Yes, sir. It's the parent body, no, sir?
Yes.
Sir, and when we conclude one Perfection series, weeks before that, we have started thinking of the next and the third one. And we just go, I travel everywhere. I see what spark I see in a particular speaker. The whole series is woven around that one person. That person should be in perfection. That should be the star of the perfection. And we weave the whole program around that. Thank you, sir.
If possible, I would also like to suggest that if possible, try also to be associated with ICOG to take its credit hours points, if possible.
Yes. Bilkul, sir. So we are taking credit points in Symbiosis, but I'll have to consult with Dr. Pratik whether we can do the same for ISAR conference. Yes.
We can do. Monica, we can do.
Yeah. So Dr. Manisha, will please take it forward from here.
Sure, ma'am.
Now we welcome our guests of honor today. This evening, we are very delighted to welcome as guest of honor Professor Dr. Sampath Kumari ma'am. I first interacted with her in Indore, and she came across a very warm and affable person. Because I'm a little new in Foxy, so I didn't know so many dignitaries. But when I came in touch with her, I realized how warm a person she is, and we found a common friend in Bhopal, her friend, Dr. Matri Chandra, past chair, HIV committee. So Madam has been the South Zone Vice President in 2022, and she has held several important posts in Tamil Nadu, Dr. M.G. Ramachandran Medical University. She has been active in Jogi. She's the founder secretary of TNFOG and very active in the Institute of Obs and Gynae MMC Chennai, and a great academician, first ICOG Distinguished Governing Council Member Award recipient in 21, Chairman of Women's Wing of IMA of Chennai South, and IMA National President Award winner, and IMA TNSB Award winner. Madam, we are truly, blessed to have you amongst us, and kindly we are waiting for your address, ma'am.
Thank you, Dr. Manisha and Monica. I am really happy to be here in this important series of the webinars. See, today is your 12th series, and today date is also 12. What such a coincidence, really. So I should, my regards to the past president, Dr. Nandita, and the present president is Dr. Amit Patki, and the secretary, Dr. Asha Bakshi. We both were VP last year. So after being the VP, we both are close friends, really. Asha Bakshi is a nice person. And the managing committee members, Monica, Randir, Fezi Louis, and Pratik Tambe, and embryologist. And you have a wonderful talk. This fertility preservation is very, very, and regards to the chief guest, our Dr. Alpesh Gandhi. Yesterday, Dr. Alpesh Gandhi was here for our annual conference. He is a nice person, as you told. He used that COVID period and made it as an academic year. All books, GCPS, guidelines, every day, environmental day, menstrual hygiene day, each day, we had a good webinar and we made use of the Zoom because of Dr. Alpesh Gandhi, I think. Thank you, Dr. Alpesh, sir. And the topic, the theme of your today's webinar, fertility preservation. First, you have the clinical discussions on the fertility preservation in cancer patient, and fertility by Dr. Madhuri Patel, and clinical cases by Dr. Nandita, and fertility preservation in adolescent, my dear friend Dr. Asha Bakshi, and the need of the fertility preservation today by Dr. Shurma. And you have the panel, our boss, Chennai boss, Dr. B.M. Gopinath, and the expert being Dr. Fezi Louis, and the entire chairpersons and the panelists. Wonderful talking, because all the patients, doctors here in Tapisar, that Tapisar is the Tamil Nadu branch, no? They talk about this series. Everyone is almost attending all the series of this. Yesterday, Dr. Kalpana was also talking about this wonderful series, and they are all benefited. And I wish you all the success for the success of this webinar, and in future for your whatever post you take. Thank you, Dr. Monica and the entire team. Thank you. All the best. And my guest of another guest, Dr. Magesh, I forgot him. I'm happy to be with him as the guest of honor. Thank you.
Thank you, Sampath ma'am, for those very sweet words. And I also extend a very warm welcome. We are delighted to have amongst us our guest of honor, Dr. Mahesh Koregal, sir. And we have always heard such brilliant things about Dr. Mahesh, and we can see from his CV, like he is one of the stars in IVF scene of India, practicing since more than 2 decades. And he is one of the key executive members of Kasoga South Zone, Vice President-elect of BSOG, held several important posts in Bangalore Society of Obs and Gynae, which is one of the largest societies of FOGSI in India. Sir is also a member of various prominent organizations. He is an avid teacher, and he is also a reviewer of the journal, International Journal of Infertility and Fetal Medicine. So we know that he has interest in fetal medicine also. He has published several research papers in international index scientific journals as first author, and we cannot wait to hear from him now. And we'll surely have him as a speaker in our subsequent programs.
Thank you for that wonderful introduction, Dr. Monica. And I really appreciate the Perfection series that is started by you and Dr. Monica Singh, Dr. Randir Singh. And this is one of the best series, I could say. I attended many series, and this is very precise and up to the point, and all topics are well chosen. And today's topic, especially being the fertility preservation, it is especially it is chosen when we are celebrating Women's Day. When we are celebrating Women's Day, it is very important to have the freedom of reproductive rights also. So I myself do around 4 to 5 oocyte freezing now every month. So the rate of people, the number of people who are freezing their oocytes is becoming increased, maybe lifestyle related or maybe because of cancer. So I myself do so many, and I feel that the freedom, kind of freedom it gives to pursue the career and education is phenomenal, and it is very well thought topic for the Women's Day celebration, which is just done. And I congratulate Dr. Monica Singh, Dr. Randir Singh for such a nice topic, and wonderful plethora of speakers, and good friend Dr. Faisal Louis and Dr. Patik Tambe also are there today, and our seniors, Dr. Amit Patki sir, the president of ISAR, has kindly graced the occasion, and Dr. Asha Bakshi madam is going to take a topic which I'm very sure it will be going to be one of the best, and Dr. Chardat Joshi sir, who is one of the pioneers of the AIT Bank, and we look up to him for any queries regarding AIT Bank. And today's speakers, our own Dr. Madhuri Patil madam, who is the vice president of ISAR from Bangalore, a very knowledgeable teacher and a mentor for all of us in Bangalore, who will be speaking on preservation techniques in cancer patients. So we are really looking forward to madam's talk, and we'll be looking forward to Dr. Andisha Palshetkar madam's talk, which is clinical aspects of fertility preservation, and a wonderful panel discussion by our senior Gopinath sir and Faisal Louis, and wonderful panelists. And at the outset, I congratulate Dr. Monica Singh and Dr. Randir Singh and the team for excellent topic chosen on Women's Day celebration, this one on the day, and it marks the forethought of the team in thinking what is beyond what other fertility procedures are being taught. I really congratulate and wish best for the team, and I wish best for Monica madam for future vendors. Thank you.
Thank you. Thank you, Mahesh.
Thank you, Mahesh.
Those were very encouraging words, Mahesh sir. And now, without further ado, we have welcomed all dignitaries and really been, happy to listen to them and how they think about our series. It's very, very encouraging indeed. And now you must be knowing the force behind my series is my two girls, my Manisha is a very senior gynecologist. She's a professor in medical college, and Dr. Purnima is one of the most bright, alumni of Maulana Azad Medical College, Lady Harding, and she is also a fellow of reproductive medicine. She's worked in AIIMS Nagpur. Now she is in Apollo Hospital, Bhopal, and she's a very dynamic young lady. And really, because of these two, my work becomes so much easy. Dr. Manisha is also very active in Bhopal Obstetrics and Gynae Society. She handles all the funds. She's a treasurer, but she's always lending a helping hand to the president, secretary, me, everyone. She also is a very active member of MPOX, that is All MP OBG Society. She is a good teacher. She writes, she publishes, and she is very popular amongst her students. Thank you, Manisha and Purnima. You can take the program forward from here.
Thank you so much, ma'am, for your kind words. Ma'am, since we had first session with Dr. Nandita madam, but I think madam is unable to join us right now due to some situation. So Madhuri ma'am, can we take your lecture first? Ma'am, you are muted, ma'am.
Yeah, you can go on.
Thank you, ma'am. Thank you so much. So let's move forward for our next session. And our speaker is Dr. Madhuri Patil, ma'am, and topic is fertility preservation techniques in cancer patients and overview. And chairpersons are Dr. Amrita Sarkari Jaipuria madam and Dr. Randir Singh sir, because Dr. Sangeeta madam is not able to join us today. Dr. Amrita Sarkari Jaipuria madam is President Gorakhpur Menopause Society, past President Gorakhpur Obs Gynae Society. Madam is currently consultant and gynecologist at Jaipuria Medical and Research Center, Garg Hospital.
Thank you, Dr. Purnima. Let's move.
Thank you so much, ma'am. Ma'am, can you, so I would like to hand over the session to you now. And also another chairperson, Dr. Randhir Singh, sir. Sir has already been introduced and sir,
Yeah. Continue,
convener
continue.
of this series. Thank you so much for our chairperson. Thank you. Amrita, ma'am.
Yeah. So we are, thank you, Dr. Monica, for giving me the opportunity. Thanks, Asha ma'am, and the authorities of ISAR now, presently the office bearers. So the topic today is fertility preservation techniques in cancer patients, an overview. And the speaker is none other than Dr. Madhuri Patil. She is the clinical director of Patil's Fertility and Endoscopy Clinic. She is an associate editor of Fertility and Sterility of official publication of ASRM. She is the chairperson Aspire SIG Reproductive and Endocrinology. She'll be continuing till 2025. President and founder member of Fertility Preservation Society of India, Vice President and founder member, the PCOS Society of India, Vice President, Indian Society of Assisted Reproduction. She is so much decorated. I'm so proud to be here. I feel honored to be chairing the session for her. Board member, AEPCOS Society, Governing Council member, ICOG, 2021 to 2023, member Education and Accreditation Committee, Aspire and Aspire SIG Implantation, associate editor, The Oncofertility Journal, past editor-in-chief, Journal of Human Reproductive Sciences, and official publication of ISAR. Awards are many. Dr. Duru Shah Lifetime Achievement Award from ISAR 2022, Vidya Vibhushan Award from ICOG 2021. She is the founder chairperson of Karnataka chapter of Indian Society of Assisted Reproduction, principal and course coordinator and examiner for fellowship and certificate course in reproductive medicine of Rajiv Gandhi University of Health Sciences, Karnataka, ICOG and ISAR Aspire, member of International Reproductive Medicine Research Network. Publications are many, national and international journals, and written several chapters and edited several books. So the platform is all yours, Dr. Madhuri Patil.
Thank you.
I won't come in between the viewers and you. Over to you.
Thank you for that introduction, but I think the overview should have been first because we need to know that both cancer as well as cancer treatment has effect on fertility, and that is the reason why we require fertility preservation in these patients. So basically, the methods will depend upon the age of the patient, the type and diagnosis of the adjuvant therapy which is going to offer to the patient, the time available between before chemo and radiotherapy, and as well as the length of delay to childbearing post-chemo and radiotherapy. Though we know that the initial treatment plan is known to us, but the final treatment course is not known because we know that there could be a high mortality in this group of patients. There are certain issues that need to be addressed prior to recommending any fertility preservation modality. And one is that we have to look at the oncological prognosis and quality of life. And if we know that the oncological prognosis is not good, then probably we should not offer fertility preservation to these patients. We also need to look at the fertility as well as the past obstetric history, the availability and reliability of the fertility preservation technologies, the surgical modalities and expertise, and as well as cost of storage, the fate of gametes in the event of death, screening for all vital markers, explaining the meaning of success, because we know that there cannot be 100% success when you either freeze the oocytes, embryos, or ovarian tissue. We have to look at the psychosocial perspective, as well as counseling is very important. It could be individual, it could be parent if it involves children and adolescent, and couple if the patient is married, and obtaining informed consent is most important. So in the male, after diagnosis, basically it is very difficult to evaluate the germinal damage because testosterone does not change, as Leydig cells are mostly not affected. The secondary sexual characters are unchanged. Therefore, a semen analysis is required. Many resume spermatogenesis spontaneously, and damage to the gonads is different in pre as well as post-pubertal males. So if you look at the various options, in the adults, we know that sperm cryopreservation is an established technique. And if we find that there's azoospermia or the patient cannot produce a sample, then sperm cryopreservation of the sperms obtained through testicular aspiration or extraction or electroejaculation or from post-masturbation urine sample can be done. But there are very small case series on this. And the other method is testicular tissue cryopreservation and reimplantation, which has been widely tested in animals, but not in humans. And usually hormone therapy is not recommended. Whereas in children and adolescent, if it is pubertal, we know we could go for sperm cryopreservation. And there are a few cases reported of gonadal shielding. But if the boy is prepubertal, again, gonadal shielding is one of the options, and only there are a few case series. And testicular tissue cryopreservation is the only method in this group of patients. So if the patient has azoospermia at the time of diagnosis, or in adolescent, one could also go in for VAS aspiration. You can go for testicular sperm extraction and testicular tissue cryopreservation. And we know, as you can see, that the spermatogenesis starts only after puberty. Testicular tissue freezing is the only option during childhood and prepubertal age. And you can see that the seminiferous tubules do not have any sperms in prepubertal stage, whereas as compared to that in an adult. Though testicular tissue freezing is technically feasible in both pre and post-pubertal males, but it must have a transplantation protocol as well as a storage protocol, and the reproductive efficacy and safety is not present as yet. And when we do an autologous testicular transplant in humans, safety is a concern because there could be reintroduction of malignancy. The patient has to be subjected to surgery, and therefore there could be infection. And also, in some cases, especially in animal studies, there is an epigenetic stability of the germ cells, which could be a problem and has been reported. And this could be related to the damage which is caused by cryopreservation, dissociation, culture, or transplantation itself. And as I've already said, that there are no pregnancies reported in humans, though there are several pregnancies reported in animals. One must also remember that it's best to bank the sperms before starting chemotherapy, because after chemotherapy, there's always an increased risk of DNA damage as well as gene mutations. And though children conceived during chemotherapy do not show an increase in the congenital malformations, neither there is an increase in the pregnancy wastage. So this is a very good algorithm which talks about the different methods in male, adolescent, and young adults. So in those patients, one has to look at go for fertility preservation consultation. We have to discuss the various sperm collection methods, which I have already described to you. And if the patient is ready, then we need to go for consent, and we have to do the infectious disease panel and send the patient for semen analysis with cryopreservation. So if the patient is successful, we preserve the sperms. But if the patient is unable to ejaculate, then probably we could use vibratory stimulation or electroejaculation. If successful, we could cryopreserve the sample. But if the patient is still unable to ejaculate, then probably a testicular sperm extraction could be done. In patients who can ejaculate but have a spermia, then we have to do the analysis of the post-ejaculate urine. If the sperms are found, we have to repeat the collection with alpha agonist. If the patient is successful, it's okay. If not, if there's persistent spermia, then probably we need to go for oral therapy with alkaline urine, oral therapy to alkalinize the urine and instill sperm wash media into the bladder and isolate the sperms from the post-ejaculate urine. If there are no sperms found in the urine, then the only option is testicular sperms. And if the patient ejaculates but has azoospermia, we can repeat the semen analysis. If we find sperms, we freeze them. If not, then testicular tissue cryopreservation is the option. And if you look at the recommendations in this group of patients, so we can divide them into various groups. And here we have wherein we have high dose alkylating agents which cause testicular damage, and where testicular radiotherapy is obtained basically in the pubertal and post-pubertal counseling is most important. Sperm cryopreservation is strongly recommended. And if they cannot ejaculate, then we can do a testicular sperm cryopreservation. And when there's a moderate recommendation as a part of clinical trial, when we are doing testicular tissue for testicular tissue for cryopreservation, and there's also a moderate recommendation only as a part of a clinical approved protocol. Hormone suppression is not recommended. And in the pre-pubertal, it's basically the counseling and it is the testicular tissue cryopreservation. When the patient is given low dose of alkylating agents and cisplatin or orchidectomy, counseling is both in pre-pubertal and post-pubertal is important. Sperm cryopreservation is usually recommended, and there's moderate recommendation only for patients with high risk of cancer recurrence, wherein we can do it via testicular cryopreservation, or we can use electroejaculation, whereas testicular tissue is not recommended. And even in the pre-pubertal, it is not recommended. And you can see that hormone therapy also is not recommended. In patients who are subjected to cranial radiotherapy, you have to counsel, and it's a strong recommendation. Semen cryopreservation, again, is a strong recommendation, but only a moderate recommendation for patients of high risk of cancer recurrence, and testicular tissue is not recommended in both the groups. And if the patient is not at risk for infertility, then other treatment groups, basically we have to counsel them, and this has a moderate recommendation. And probably if the patient feels that it's not difficult to produce a semen sample, so you could probably cryopreserve the semen sample, but testicular tissue cryopreservation is not indicated. Coming to fertility preservation in women, we know that it's a personalized medical therapy. One-size-fits-all approach does not exist. And therefore, for every woman, a multidisciplinary group of experts should convene and analyze all the related issues prior to recommending the best option. The fertility preservation depends upon a variety of factors, each with a significant as well as unique importance. And these include patient's age, the type of the disease, the spread of the disease, the treatment which is planned, the time available before treatment, and whether the patient has a partner or not. And when we embark on fertility preservation, it's important to assess the fertility risk and ovarian reserve before and after treatment. And this is dependent on several intrinsic and extrinsic factors. The intrinsic factors include the health of the patient now and after treatment, the age of the patient, and one must assess ovarian reserve with clinical parameters like menstrual cycle, lab parameters like AMH, and antral follicular on ultrasound. The other extrinsic factors which can influence the fertility preservation results are the nature of the predicted treatment, whether it is of high, medium, low, or uncertain risk, the practicalities of fertility preservation, as well as the time, expertise, and the funding which is available for the same. One must remember that resumption of menstruation post-chemotherapy does not mean that fertility has been preserved. Moreover, before fertility preservation, it is important to know about the ovarian involvement in various cancer types to select the best method of fertility preservation for safety of ovarian grafting as a method of fertility preservation, and to evaluate the risk of ovarian metastasis according to the cancer types, whether it's low, moderate, or high. So we can divide the patients into three groups. Those with a low risk of ovarian involvement, and this is basically seen in patients with Wilms tumor, Ewing sarcoma, breast cancer stage 1 and 1 to 3, which is infiltrative ductal histological subtype, non-Hodgkin's and Hodgkin's lymphoma, non-genital rhabdomyosarcomas, osteogenic sarcoma, squamous cell carcinoma of the cervix, and endometrioid type of endometrial cancer. Cancers with moderate risk of ovarian involvement include adenocarcinoma or squamous carcinoma of the cervix, colon cancer, endometrial cancer with more than 50% of myometrial invasion, breast cancer stage 4 with an infiltrative lobular histological subtype. And those with high risk of ovarian involvement include neuroblastomas, leukemias, Burkitt's lymphoma, and fallopian tube cancer. So if the patient is at risk of fertility, then we can divide the patient into prepubertal and postpubertal. As already said, in the prepubertal, it is only the ovarian tissue biopsy and an ovarian tissue cryopreservation is only the method of choice. In post, and if she's close to her puberty, at times we could also isolate immature oocytes and then subject them to IVM and preserve the oocytes. In post-pubertal, you have the best option is to go for ovarian stimulation if time is available. And in the presence of partner, one could do embryo cryopreservation. Otherwise, oocyte cryopreservation is the method. One could also go for immature oocyte retrieval with IVM and oocyte cryopreservation, or ovarian tissue biopsy with isolation of immature oocytes and subjecting them to IVF with oocyte cryopreservation or ovarian tissue cryopreservation. Ovaropexy during pelvic irradiation should be done. GnRH agonist before and with chemotherapy, especially in patients with breast carcinoma, and fertility-sparing surgeries in early stages of cancer cervix and ovary, and medical treatment for endometrial carcinoma is given. The investigation for fertility preservation techniques still being researched include IVM with oocyte and embryo freezing, whole ovary cryopreservation, and ovarian suppression using GnRH agonist other than breast cancers. So if the treatment includes surgery for gynecological cancer, fertility preservation surgeries can be done where we could preserve the ovaries as well as the uterus, but one could also opt for cryopreservation of the oocytes, embryos, and ovarian tissue. And this goes for all the type of treatment which is available. When radiation therapy to pelvic organs is given, shielding can reduce the damage to the reproductive organs, and surgical ovarian transposition is another option apart from, as I told you, cryopreservation of oocytes, embryos, and ovarian tissue. With cytotoxic therapy with high risk of gonadal damage, one could also go for ovarian tissue cryopreservation along with that of oocytes and embryos. And when hormonal therapy for E2 sensitive cancers has been offered, cryopreservation of oocytes and embryos if the woman is more than 33 years of age, and when tamoxifen is going to be given for 5 years. But if they're going to be subjected to at-last therapy, where tamoxifen would be given for more than 10 years, then women more than 28 years should undergo fertility preservation, as we know that natural fertility diminishes with age. So of all the methods that we have discussed, we know that the established methods are cryopreservation of the oocytes as well as the embryos. And one must remember that only good quality oocytes and embryos should be cryopreserved, but there is a requirement of available time for hormonal stimulation, transvaginal ultrasound, and transvaginal ovarian puncture. Oocyte cryopreservation should be performed at centers only with adequate expertise, but one must remember that oocyte cryopreservation gives reproductive autonomy, whereas embryo cryopreservation does not give. And today, with the availability of random start ovarian stimulation protocols, we could start stimulation at any time of the menstrual cycle. So let us look at the evidence first for embryo cryopreservation. And in this paper, where they looked at the utilization rate in 54 women, what they found is that the cumulative pregnancy rate was about 66%, and the live birth rate per patient was about 44%. This paper looked at the survival rate, implantation rate, clinical pregnancy rate, and ongoing pregnancy rate, and we can see that there is no difference in either of them when a fresh embryo transfer or an elective fertility preservation is done, and in those patients where fertility preservation is done for oncological reasons, the p-value not being significant. Then there were several other papers which looked at the outcome, and they found that the embryo vitrification in cancer patients does not increase the adverse perinatal outcome. Coming to oocyte cryopreservation in cancer patients, fertility preservation using oocyte cryopreservation is a viable option for cancer patients at risk of ovarian failure, allowing women to achieve pregnancy and births and to improve their quality of life. The number of oocytes available in combination with age strongly impact the live birth rates with a great increase in the outcome with 10 to 15 oocytes being available, especially at a young age. Thus, a higher oocyte yield with fewer ovarian stimulation cycles and higher live birth rates are seen in young patients, reinforcing the importance of age in fertility preservation. This paper in 2016 concluded that the developmental competence of the cryopreserved oocyte in cancer patients seem to be comparable with oocytes of healthy women, but have suggested long-term follow-up studies because we have to determine the efficacy of the oocyte as well as embryo cryopreservation. And if you look at this paper, which was published in 2019, you can see that almost 60% of the oocyte cryopreservation was done in patients with breast cancer, followed by lymphomas, whereas all the other cancers formed a very small percentage. The same paper then looked at the number of oocytes and the embryos transferred and at the pregnancy outcome. And we can see that only in about 11 patients returned for pregnancy, and of which 4 of them had pregnancy and 50% of them had a miscarriage rate. So probably the miscarriage rate was higher when oocyte cryopreservation was done. And then came this paper in Fertility and Sterility in 2021, and they looked at the clinical pregnancy rate as well as the cumulative live birth rate in oncological and non-oncological patients, wherein you can see that's for endometriosis, this is for oncology, and the blue one is for elective fertility preservation. And you can see that there is no difference in the live birth rate or the clinical pregnancy rate. Then this paper in 2022 looked at the various cancer patients who preserve fertility, and what they found that they reported a live birth rate wherein in 22 patients, but you can see that maximum live birth rates were seen in patients who had breast cancer, that is 12 out of those 22, followed by Hodgkin's lymphoma, gynecological cancers, and chronic myeloid leukemia. This paper also looked at the difference between the oncological and non-oncological patients who underwent fertility preservation, and what they found that there was no difference basically in the oocyte survival. The oocyte fertilized embryos transferred, the clinical pregnancy rate as well as the live birth rate, and also the miscarriage rate, which were almost same in both the groups. But probably it could be a problem in adolescent because of the pubertal status, virginity, follicular ovarian status is not known. There could be there could be a problem because the parents have a role in giving consent, and the choice of FSS starting dose as a problem because there are no reliable markers of follicular ovarian status that are available at that stage. And also we have to take into consideration the suboptimal ultrasound monitoring in virgin patients because we have to rely on abdominal ultrasound, and the high estrogen levels during COS can affect the bone growth. And if you look at the oocyte competence in adolescent patients, you can see that more mature oocytes were obtained in the postmenarchal girls, and also the IVM rate in the premenarchal girls was significantly lesser as compared to postmenarchal girls, though the mean maturation rate per patient was almost similar. And most of the guidelines therefore said that in patients facing infertility due to chemotherapy or other gonadotoxic therapies, oocyte cryopreservation is recommended with appropriate counseling, which has a level B evidence, and more data are needed before this technology should be used routinely in lieu of embryo cryopreservation, which also has a level B evidence. We also know that we could collect immature oocytes, and this could be done either by transvaginal ultrasound-guided aspiration, or basically when you're going for ovarian tissue cryopreservation, when you're dissecting the ovarian tissue for freezing, and when you look at this fluid, the culture media, you can find several immature oocytes, which can then be subjected to in vitro maturation, and the oocytes can be cryopreserved. This paper looked at the immature oocytes for fertility preservation, And what they concluded was that healthy live births are achieved with IVM oocytes after vitrification in patients like PCOS, but there are no live births that have been reported using cryopreserved oocyte generated from the IVF program of cancer patients, though they have been stored. The efficiency of IVM oocyte cryopreservation is still low and requires further improvement in IVM and or the cryotechnology, and also an improved understanding of mechanisms regulating IVF and developing optimal IVM media, which may give rise to more refined vitrification methods for oocytes before and after IVF. And this paper in 2018 looked at the differences between IVF fertilization preservation and IVM fertility preservation. And what they found that in IVM, the maturation rate after 48 hours was about 58%. The number of M2 oocytes was significantly lower, as you can see over here, and the number of oocytes and as well as the embryos cryopreserved were also significantly lower. The third method we know is ovarian cortex cryopreservation and an orthotopic transplant, wherein you remove the ovarian cortex, we take a biopsy, we then separate out the cortical tissue and divide them into small pieces, and then these are frozen. And after the cancer is cured, one can re-implant the cortical tissue. Though initially it was thought to be an experimental procedure, in 2019, it has been accepted as a fertility preservation technique and is no longer considered experimental. It has been basically been proposed for prepubertal females, since ovarian stimulation and IVF are not options, and for those who cannot delay cancer treatment to undergo ovarian stimulation and oocyte retrieval. The most important thing is that with ovarian tissue cryopreservation, it allows preservation not only of reproductive function, but also of the steroidogenic function. And it can be performed at any time of the menstrual cycle and allows to preserve high number of primordial follicles. But one must remember that we have to follow certain selection criteria before we do this procedure. One is the age has to be below 35, and it could be flexible basically depending upon the AMH, because if the AMH values are low, the ovarian tissue cryopreservation is not going to help, because there is loss of follicles during the storage and also during the thawing. When there is high risk of premature ovarian failure, the realistic chance of 5-year survival is good. There are no previous chemotherapy or radiotherapy given if the age is 15 years or older. But if the age is less than 15 years and the chemotherapy given is basically mildly gonadotoxic, then one can still go ahead and freeze the ovarian tissue. The most important is that it should not be affected by cancer, so that there should be no disseminated disease in the ovaries. There should be no contraindication for surgery as well as anesthesia, and informed consent from both the patient as well as parents, especially in the prepubertal girls, is important. There are a lot of factors then which could really affect the longevity of ovarian tissue graft, and this include the age at the time of cryopreservation, the baseline ovarian reserve, history of cancer treatment, technique of ovarian tissue preparation, freezing and thawing protocols, the number of cortical sections grafted, the transplantation techniques and the graft size, the degree of ischemia after transplantation, and the number of follicles surviving after the ovarian graft has been done. And here you can clearly see that in almost 78% of the patients, the FSH levels come down, and this happens after about 3 to 5 months, 5 months after reimplantation of the ovarian tissue. Here, the ovarian tissue cryopreservation was done at 10 and 9 years, and once after about 4 to 5 years after cancer therapy, when ovarian tissue was transplanted, both these patients had puberty and normal menstrual cycle. And if you look at the endocrine function following the ovarian tissue transplant, we can see that it lasts enough for 12 years. And after 12 months, basically, it gradually starts reducing. And after 2 years, it is significantly less. But we could do repeat transplantations, and this can prolong the endocrine function but it seems to be less successful in terms of pregnancy, either both spontaneously or with IVF. And here we can see there are several patients which have shown that there have been live births reported from the frozen thawed ovarian tissue transplantation before, both after prepubertal as well as postpubertal OTC. And the last paper published which reported the live birth rates was in 2019, and it has shown about total of 185 pregnancies with a pregnancy rate of 58% and a live birth rate of 65%. And you can see that 50% of them were spontaneous pregnancies and only 33% required ART. This paper again shows the same thing, and you can see that the number of pregnancies and deliveries with spontaneously are significantly higher as compared to ART, and overall the pregnancy rate was 41%. This paper in 2022 also looked at the fresh and cryopreserved ovarian tissue transplantation, and they found that after transplantation, there's increase in estrogen in about 75%, decrease in FSH in 78%, and LH in 67%, with a pregnancy rate of 37%, a live birth rate of 28%, and a miscarriage rate of 37%. This was a paper which was published last year and looked at all the different methods, and you can see that the live birth rate after an embryo transfer was the highest when embryo cryopreservation was done, and that with oocyte and OTC after spontaneous conception of OTC was almost similar, that is 32 and 33%, whereas with OTC and IVF, it was about 21%. Then coming to GnRH analogs, which can protect the ovary by three different mechanisms. One is by decreasing the ovarian perfusion, which then decreases the ovarian exposure to chemotherapy. It also has a direct anti-apoptotic effect on the anti-apoptotic ovarian molecules. And basically, it decreases the FSH and thus mimics pre-puberty and thus reduces the growing follicles, because we know that the chemotherapeutic agents basically affect maximally the growing follicles and not the primordial follicles, and therefore probably should be considered as a reliable strategy to preserve ovarian function and fertility. This paper said and concluded that use of GnRH agonists are conflicting because the surrogate markers used in many trials do not really reflect the successful pregnancies, and therefore just relying on the hormonal levels, resumption of menses might not be a good endpoint to look at, and one must look at the live birth rates. And they said that probably it's a proven method in breast cancer patients, but it can be used in other patients to minimize the symptoms and complications which are related to premature ovarian insufficiency. And this paper looked and demonstrated safety and efficacy in breast cancer with high number of post-treatment pregnancies, and it also did not have any impact on the disease-free survival. Whereas with other malignancies, there was protection against chemotherapy-induced POI, but there were no pregnancies that were reported. And basically, here you can clearly see that it reduced the risk of chemotherapy-induced POI, which was only 20% as against 34% if GnRH agonist was not used. And the pregnancy rates basically were not significantly higher, though statistically higher. And therefore, the ASHRAE guidelines also recommends use of GnRH agonist in breast cancer patients, whereas in other patients, if we use them, we need to tell them that it is still experimental and does not have a proven effect. We also know that oophoropexy is done to protect the ovaries from pelvic irradiation. It is basically the ovaries are moved and sutured into the paracolic gutters, and it is basically done close to the radiation. The protection may be 50% because at times there could be a spontaneous ovarian relocation. It could be affected by scattering irradiation, as well as it can decrease the ovarian blood supply, and pregnancy has been reported. At this time, one could also opt for preserving the ovarian tissue, because in case the ovaries are not protected, we have another option which is available. This was a paper which was published last year, and here you can see that they have done a uterine transposition for fertility and ovarian function preservation after radiotherapy in non-gynec malignancies. And they have done it in 8 patients, 7 of them with rectal cancer and 1 with pelvic liposarcoma. And the uterus was successfully preserved in 6 out of these 8 patients because 1 patient died. And in 1 patient, there was uterine necrosis and therefore they had to do an hysterectomy. And what they did is they bought the cervix at the umbilicus, and the menstruation basically happened from the umbilicus. And in many cases, cervical ischemia was reported, and the incidence was about 37.5%. 3 patients who attempted to conceive, 2 of them conceived successfully and delivered healthy babies at 36 to 38 weeks without any complications. Thus, uterine transposition is a feasible procedure for preserving gonadal and uterine function in patients requiring radiotherapy for non-gynecological cancers, facilitating spontaneous pregnancy and successful delivery. Clinical examination and Doppler ultrasound were used to evaluate the gonadal vasculature post-surgery, and the uterus was repositioned into the pelvis 2 to 4 weeks after radiation therapy or at the time of rectosigmoid resection in patients with rectal cancer who had undergone neoadjuvant treatments. So apart from the fertility preservation procedures, fertility-sparing surgeries can be offered to gynecological cancers, especially in early stages of CA cervix, endometrium, and ovary. And basically, we have to look at the patient's age, the stage and type of tumor, and the need of adjuvant therapy. In cervical cancer, stage 1, A1, A2, stage 1B, and 2A, when there's no sentinel node affection, colonization, simple trachelectomy, or radical trachelectomy can be done. In endometrial cancer, type 1, stage 1, grade 1, medical therapy with progesterone, either oral or LNG, is advocated. In ovarian cancer, where there is borderline ovarian tumors, epithelial ovarian cancer, stage 1A, grade 1, stage 1A, grade 2, germ cell tumors, grade 1, a cystectomy, either unilateral or bilateral, or a unilateral salpingo-oophorectomy is done. In vulval and vaginal cancers, a wide excision in early vulval cancers, whereas in fallopian tube cancers, fertility preservation is not advocated. And if fertility-sparing surgeries is not possible, then other fertility preservation methods should be considered. Coming in GTNs, basically, we do not require because these really do not affect the ovaries. But when other drugs are used probably, and in refractory cases, we need to probably go for fertility preservation. One could also create artificial gametes from stem cells. In humans, it is still experimental, and we know that it has a lot of ethical and social issues. Stem cells may also be used to regenerate dysfunctional uteri and to promote vaginal construction and regeneration. And uterine transplant is also one of the options, though it's not done in cancer patients yet, but it's done in patients with Mayer-Rokitansky-Kushner-Hauser syndrome, and there's 19 children have been born till today. Safety of fertility preservation techniques has been proven because there is no detectable increased risk of disease recurrence with most fertility preservation methods and pregnancy, even in hormonally-sensitive tumors. Cancer treatment has mutagenic effect on oocyte present in growing follicles, and risk is related to the stage of the oocyte development during exposure and the drug regimes used. And therefore, basically, one should go for pregnancy 2 years post-treatment. It has also been seen that cancer therapy or fertility preservation does not increase the risk of cancer, chromosomal abnormalities, or congenital abnormalities of fetal malformations in the offspring if conception happens 1 year after cessation of treatment. And this is seen in the breast cancer patients, where you can see that the pregnancy does not affect the survival in this group of patients. So I would like to end with the following take-home messages, that we still have several barriers to fertility preservation in adolescent and young cancer patients, and they are cost, cultural barriers, effect of the disease process, as well as religious concerns. There could be acute clinical issues because survival is only the focus. There could be lack of comfort, knowledge, or training, and therefore it's not been provided. And there could be lack of specialities, coordinators, infrastructures, as well as resources, because we know that in IVF is not covered under insurance, and the patient has to bear the cost of cancer treatment as well as of IVF. So I would end with the following recommendations, saying that oncology clinicians must focus not just on the goal of eradicating disease, but also on mitigating the long-term effects of the treatment. One must discuss fertility preservation with all patients and also in children, but it may be limited in children because of the sexual immaturity, and these methods are essentially experimental. We also should refer the interested patients to the reproductive specialist and provide direction when they are ready to build a family after treatment is complete. One needs to prevent, diagnose, and treat sexual concerns apart from just reproductive concerns throughout the course of cancer treatment as well as survivorship. And therefore, a collaboration among the reproductive physicians, biologists, endocrinologists, oncologists, surgeons, and psychologists and gynecologists is necessary to ensure the best fertility preservation program for each patient. And therefore, this should be the treatment plan, because once after oncology concentration, the treatment plan is decided. And if there's risk, one has to refer for fertility preservation. And after the fertility preservation consultant sees, either they go for fertility preservation or expected management and then start the cancer treatment. The Fertility Preservation Society has published these recommendations on fertility preservation for patients on gonadotoxic therapy, and these can be obtained online at the website of the Oncofertility Journal in the July-December 2020 issue. And I also invite you all to the International Society of Fertility Preservation annual conference to be held in Japan. I thank you all for a patient hearing.
Thank you, ma'am. Thank you for such an elaborate and informative talk. And it was very, very encouraging also to see that anybody suffering from deadly disease has a fertile future also. And ma'am, just a question that what about the legal aspect if some patient dies and her ovary is preserved or the embryo is preserved, or
there are consents which are available for posthumous reproduction. So basically in India, still according to the ART law, we've still not got any guidance on that. But if the consent has been given by the patient, especially in the males, wherein their sperms could be used posthumously, then one could use them. If we don't have a consent from the patient, then we cannot use either the sperm oocytes or the embryos posthumously.
Okay, ma'am. Thank you so much, ma'am. It was very, very
Yes, ma'am. Fantastic lecture, Madhuri, ma'am. You covered every aspect, and you're really a master in this area, ma'am. And it is very, disturbing that CA breast is forming the largest chunk. Means cervix is just, CA cervix is a very minuscule part of the whole spectrum, the pie chart, ma'am. CA breast is really it's raging.
Considerably. And especially in young patients, now we also have patients in their 20s who come with CA breast for fertility preservation.
And I think the younger the age group, more aggressive is the CA of the breast, ma'am.
Basically,
yes, ma'am. Okay, you go ahead, ma'am.
Whether they are ERP positive, they're triple negative.
Yes, ma'am. Yes, ma'am.
Negative,
yes.
So it depends on that. So if they're triple negative, the prognosis is bad.
So, ma'am, you think BRCA testing should be made more accessible, and there are some patients who are asking about.
Is that with when the patients are positive for BRCA1, then the incidence of breast cancer is also higher, and in these patients who have a higher incidence of breast cancer, also have a higher incidence of having ovarian malignancy. And therefore, usually in these patients who are BRCA positive, they have completed their family, who have undergone treatment for breast cancer, should undergo a hysterectomy with bilateral oophorectomy.
And ma'am, the cases which you showed, the cervix has been transposed to the umbilicus. Those are for cervical radiotherapy, the cases?
These
are some other cases.
Gynecological malignancies. So this was the only one publication which I could, which has recently been there, and wherein they've done only in 8 patients in non-gynecological, especially they were all for rectal malignancies. So where they were given radiotherapy. So to prevent the uterus as well as the ovaries, they have transposed this. This is the first study which has been published on uterine transposition, but there are several studies which have been published on ovarian transposition.
So, ma'am, there would be no scope of preserving the ovaries of such patients who are BRCA positive.
Yeah, so what they say is if the patient is BRCA positive, after you treat it, then you go for fertility preservation, wherein you can freeze their ovaries or embryos and ovarian, and basically ovarian tissue is not advised in these patients because there is a chance that there could be a malignancy. And if at all it is preserved, then you have to subject it to immunohistochemistry before you transplant the tissue.
Okay, ma'am. Thank you so much.
Thank you, ma'am. I just got a call from Nandita, ma'am, so I had to, in between, I had to leave.
Not do it, I can do that talk also in case if she doesn't come, I can do it. No issues.
Madam, she will be joining around 5:45, so we have some time. I think Dr. Asha Bakshi, ma'am, can finish the talk on adolescents. And then Dr. Nandita has just come out from OT. She had an emergency, and she'll be joining in another 25 minutes. or so.
Monica, ma'am.
Yeah.
Yeah.
Yes, I'm there.
Yes, ma'am.
Yeah. So thank you, Madhuri, ma'am, for that lecture. Purnima, can we go to speaker 2, please?
Yes, ma'am. Thank you, Madhuri, ma'am. I want to say one thing, Madhuri, ma'am. I am a big fan of you and your academics and your in-depth knowledge. You might not remember me, but I was your student during my fellowship time. And whenever I used to listen your lecture, and today also I was making notes. So thank you so much, ma'am, for this wonderful talk. So let's move forward for our next session. For this session, our speaker is Dr. Asha Bakshi, madam, and the topic is fertility preservation in adolescents. And our chairpersons are Dr. Om Sheila Gulia, madam, and Dr. Surjit Kaur, madam. Dr. Om Sheila Gulia, madam, is President Bhiwani Obs and Gynae Society. She is senior consultant and having experience of more than 3 decades, and she is life member of SR IMN IMAAMS. Thank you so much, madam, for joining us today. And welcome on this platform. Our next chairperson is Dr. Surjit Kaur, madam. Madam is past president Jalandhar Obs and Gynae Society. She is currently director at Parivar IVF Center, Jalandhar. She has been past chapter secretary IMS Jalandhar. She has organized various CME conferences and camps in urban and rural areas, and she has done a lot of social activities. Thank you so much, madam, for joining us today. So now I would like to hand over the session to our chairpersons for introduction of our speaker. Thank you so much. Sheila, ma'am.
Hello, good evening, everyone. Am I audible?
Yes, ma'am.
Yes. Yes, ma'am.
Thank you, dear, for inviting me for such an important topic. And I have a privilege to introduce our next speaker, Dr. Asha Bakshi. Dr. Asha Bakshi is Secretary ISAR. She is member of Executive Committee AICC RCOG West Zone. She is founder chairperson of MP IAGE and MP ISAR. She is member of Advisory Committee PCPNDT Indore.
I think that's enough. That's enough because already you have introduced me before also, no? So you can just
there are many awards to her credit. She is recipient of Kumud Tamaskar Award and she is Padam Shri Dr. S.K. Mukherjee Award. She was the organizing chairperson of AICOG 2022 and organizing chairperson New Age OG Con 23 Indore. Her topic today is fertility preservation in adolescents. So Dr. Asha Anil Bakshi.
Thank you so much. Can I get the permission to, share my screen? Yeah, yes. Already Dr. Madhuri has really spoken very well, so there is a little for me to, but lots of things are going to be the repetition. So let's talk about fertility preservation in adolescents. And today, the survival rates for children and adolescents diagnosed with malignancy have been increasing steadily because of the advances in the oncology treatment. And there are many oncological as well as non-oncological conditions and related therapy, which may raise problem for the fertility in future. and failing to achieve parenthood raises tremendous psychological stress on patients and their families and impairs their well-being. Awareness regarding fertility preservation for adolescents is lacking amongst most of the healthcare professionals. Availability of fertility preservation treatment and their success makes it important to discuss this issue prior to oncological treatment and in some non-oncological conditions. So in the past, you heard Dr. Madhuri that these days so many things are available for the fertility preservation. So in this era, if you don't discuss this or these options before before starting the treatment, I think it's a pure negligence, and you have to consider fertility preservation techniques. You have to discuss with the patient. If patient wants it or not, or relatives want it or not, that is a different issue. But I think we have to discuss these things. So what are the indications? The indications may be oncological prior to chemotherapy and radiotherapy, and certain non-oncological conditions, some autoimmune diseases and all are there where gonadotoxic agents are used, and in that situation also this has to be considered. So coming to the oncological causes, 80% of the cancer in adolescents we know these days are curable, and chemotherapy and radiotherapy leads to temporary, long and permanent gonadal toxicity. This leads to fertility impairment in future in cancer survivors. Alkylating agents are very highly toxic, both in the males as well as in females, and they may have low toxicity, medium toxicity, or high toxicity. And overall, there is threefold rise in chances of premature ovarian failure after the chemotherapy. Ovarian radiation causes almost 50% depletion at the dose of 2 grams, 60% at the dose of 2.5 and 5. Overall, there is significant decline in AMH levels. Similarly, spermatogenesis is also sensitive to chemotherapy and radiotherapy. 25 to 28% survivors have oligo or azoospermia, when especially after cyclophosphamide. When cyclophosphamide is given at the dose of 7,500 mg per square meter, all patients had azoospermia. And radiation at 0.1 gray can affect spermatogonia, and doses above this affect the spermatocytes and spermatid. Studies have suggested that radiation more than 6 gray leads to permanent infertility. So non-oncological causes, there are many autoimmune diseases like SLE and all those things. Then there may be some hematopoietic stem cell transplantation procedures where you have to give chemotherapy like beta thalassemia major, severe aplastic anemia. Then other conditions that can cause premature ovarian insufficiency, especially the genetic causes like Turner syndrome, Klinefelter syndrome, fragile egg syndrome. Even in endometriosis, young girls, we know these days even young girls are getting endometriosis. And in these girls also, it's very important to discuss think about their ovarian reserve and discuss about oocyte freezing. Then ovarian and testicular torsion, benign ovarian tumors, galactosemia, all these things can cause premature ovarian insufficiency or spermatogenic failure. And transgender population is also another area where these things are important. So there are lots of available options for fertility preservation these days. And first and commonest is oocyte cryopreservation. And these days we all are using this technique otherwise also. So nowadays it's not so difficult to do the oocyte cryopreservation. And here we need controlled ovarian hyperstimulation so that we can form the follicles and then retrieve the oocytes. But this again needs some time. So, and at the same time, estradiol levels will be high. So you have to keep all this in mind, that do we have enough time before starting the chemotherapy to do the ovarian stimulation? And there may be high estradiol levels, so that all needs to be discussed. And these days, there are certain protocols, as Dr. Madhuri has discussed, the random start protocol. So those protocols can be used. Then GnRH antagonist protocol is especially considered to be optimum for short time and safely. Immature oocytes can be obtained at the time of ovarian tissue cryopreservation or oophorectomy. And Dr. Madhuri had beautifully shown that transection of the ovary from where the fluid can be taken out. And immature oocytes can be obtained at the time of ovarian tissue and that already she has shown. Then GnRH agonist protection, that has also been discussed in details. The clinical efficacy during chemotherapy is controversial and current recommendations regarding its use remain conflicting. A prospective study found GnRH analog administration during chemotherapy protected ovarian function and preserved fertility in adolescent patients. Well-designed, large, prospective, randomized controlled trials are essential to determine the protective effect of GnRH analog in children and adolescent patients. But I think this is something really very simple and it can be easily practiced. And these days, the GnRH analog depot preparations are available, which are effective for 3 months. So such preparations can be used, and maybe it's a good idea. Coming to ovarian tissue cryopreservation, it is perhaps the sole option for fertility, especially in the pre-pubertal and post-pubertal adolescents who cannot, or in those who we cannot delay the start of chemotherapy. Roughly 50% of cortex from one ovary is surgically removed, dissected, and cryopreserved for future use. The ovarian tissue is cryopreserved by either slow freezing or vitrification. When a patient intends to restore ovarian function or fertility, the cryopreserved tissue can be thawed and replaced back. Multiple transplantation strategies have been developed. Coming to orthotopic transplantation, the frozen ovarian tissue can be replaced back either orthotopically or heterotopically. Orthotopic sites include remaining ovary and the peritoneal pockets created on the broad ligament. Now, this provides the possibility of because of the anatomy. Naturally, if it is going to be near the tube, so then the chances of spontaneous conception are also possible with this type of transplantation. Coming to heterotopic transplantation, this is the ovarian tissue is replaced in subcutaneous areas like forearm, abdominal wall, chest wall, breast, rectus muscle, and subperitoneal tissue. It is less invasive, easy follicular monitoring and oocyte retrieval can be done for IVF, easy monitoring for cancer recurrence and removal of the graft if necessary, and it is more cost effective, especially in cases of repetitive transplantations. For some females who wish to restore ovarian function but do not desire pregnancy, these advantages probably make heterotopic autograft a potential preferable option, because these are once you replace the ovarian tissue, there are two benefits. One is getting the oocytes and other is the steroidogenesis. That means you'll be getting your estrogens. So coming to fertility preservation in male adolescents. So for those who are able to give the sample, the sperm cryopreservation is the best thing. The sample is obtained through the masturbation and most reliable method. Penile vibrostimulation is a non-invasive method and it can be alternative when there are difficulties with the masturbation. However, considering the invasiveness, electroejaculation and testicular sperm extraction should be conducted only after weighing the benefits and harms. Now, cryopreservation of immature testicular tissue is only fertility preservation option for prepubertal boys as spermatogenesis is absent. Small pieces of immature testicular tissue are surgically removed for cryopreservation. Clinical outcomes after fertility preservation. So if you have done oocyte cryopreservation in adolescent, it is quite effective and the clinical outcome using cryopreserved mature oocytes have been steadily improving. The clinical outcomes between vitrified oocytes and fresh oocytes are similar. For vitrified oocytes, I think Dr. Madhuri has shown the beautiful studies and the tables. So for vitrified oocytes, ICSI is used instead of IVF, because whenever you do vitrification, you remove the cumulus and immediately freeze these eggs. So for those eggs without the cumulus, ICSI is the only possibility. Fertilization with ICSI occurs in 70 to 80% and implantation rates are almost 40% per embryo transfer. Oocyte aneuploidy from women under 20 have been reported to be higher as compared to those between 20 to 30 years. So that thing has to be kept in mind. Now, clinical outcomes after ovarian tissue cryopreservation. This is the sole option, as we have already discussed, for fertility preservation in the pre-pubertal girls, and also those in whom it is not possible to start the chemotherapy immediately. I think we have already discussed this. So sperm and testicular tissue cryopreservation. Higher success rate is obtained in ICSI as compared to IUI and IVF. Longest duration of sperm cryopreservation to date is more than 28 years, which successfully resulted in a healthy live birth with IUI. So the results are quite satisfactory. The documented clinical pregnancy rates using thawed sperm collected before cancer therapy ranges from 18 to 57%. For those patients who had their testicular tissue cryopreserved, the fertility restoration strategy includes autologous grafting of immature testicular tissue, injection of testicular stem cells into the testis, and in vitro maturation of testicular stem cells. Now, coming to transgender population, this is again a very upcoming issue. And transgender individuals represent a special population who recognize internal gender as different from the biological gender. To alleviate gender dysphoria, many of them choose gender affirming therapy, including gender affirming hormone therapy, GAHT, and gender affirming surgery, which is known as GAS, rendering the temporary subfertility or permanent sterility. Considering most transgender persons are reluctant to postpone or suspend gender affirming therapy, it appears even more important to start consultation as soon as possible. So whenever such issue arises, the plastic surgeon usually discusses this with the fertility specialist as well. Now, for these males, for the trans males, oocyte cryopreservation, embryo preservation, and ovarian tissue cryopreservation are established methods for fertility preservation. For trans men who have not started the hormone therapy, ovarian stimulation protocols are the same as those used for routine infertility. GnRH antagonist protocol can be considered for its efficacy in oocyte yield, and the addition of letrozole can reduce the estradiol levels and related symptoms. For pre-puberty trans men and those who are unwilling to accept ovarian stimulation, ovarian tissue cryopreservation is the sole option for fertility preservation. Auto-transplantation of cryopreserved ovarian tissue has resulted in more than 200 live births. Fertility preservation for the trans women. So here, the sperm cryopreservation is a reliable option for these trans women. Sperm may be obtained by either masturbation, assisted ejaculation, or TSA. Cryopreserved sperm should be used for IUI, alternatively IVF ICSI, using oocyte from a donor or cisgender female partner. For prepubertal transgender girls, testicular tissue cryopreservation remains the only option, as in other cases. Then fertility preservation program. The current challenges are that there is limited knowledge of clinical practice guidelines and poor compliance with recommendations by medical professions. Most patients and their parents are dissatisfied with the content of information that healthcare professionals provided concerning fertility risk and available options to preserve it. And probably it is overall the awareness is not there. So the major barrier hindering the preferable fertility preservation practice is the lack of structured and coordinated fertility preservation program. Education of healthcare professionals is very, very important. Clinicians' knowledge and attitude towards fertility preservation significantly influences the fertility preservation practice. While some physicians have realized the sensitivity and importance of fertility issues, oncologists tend to provide treatments that maximizes the chances of survival and regard fertility issues as non-priority. And it is not only these oncologists, even the parents. I have had 2 or 3 patients where the medical oncologist, he referred these patients to me for fertility preservation. And when I discussed with them, then they said, at the moment, we are just bothered about cancer. We are not bothered about the eggs. And if at all, what will happen? There will be no eggs. We will take donor eggs. So we are least bothered. So I think the reason is that in India, for every treatment, the patient has to pay. And we don't have any government aided programs, because if that is there, then the things will be different. But when patient has to pay and they don't know how much they have to pay in this cancer treatment itself, so they are least bothered about their fertility preservation. So accomplishing the objectives should start with educating healthcare professionals, possibly including pediatric oncologists, radiation oncologists, gynecologists, urologists, hematologists, surgeons, and nurses. So wherever these patients go, they should have, people should give them information about fertility preservation. And informed consent is very important. So a formal and separate discussion about fertility issues is advocated to ensure patients' full comprehension of potential fertility risk and fertility preservation options. Importantly, considering the sensitive nature of the age group and topics, patients should be offered a chance to speak freely without the presence of their parents, and especially when people are going in for gender change therapy. That is the time when I think you need to discuss with both of them. In addition, institutions can design printed or online educational material for interested patients and the ordinary public to facilitate information provision. The provision of relevant medical information should be documented in the patient's medical record, and patients who decide to seek fertility preservation must provide written informed consent. And about the referral, the establishment of a standardized intra-institutional or inter-institutional referral sub-pathway is important. Collaboration of oncologists with fertility specialists is again important, and there should be a direct link between the clinical team and the fertility preservation team. So future directions are: there is massive follicular atresia after transplantation with more than 70% of primordial follicles failing to survive. Future studies should focus on promoting follicular survival by enhancing revascularization and reducing ischemia reperfusion injury soon after the transplantation. Then potential strategies like transplanting ovarian tissue with biocompatible decellularized extracellular matrix scaffold and the utilization of antioxidants with anti-apoptotic agents and pro-angiogenic factors may improve the outcome. Artificial ovary and complete in vitro development of follicles are potential strategies for female fertility restoration. Testicular tissue autograft needs many clinical trials. So the conclusion is fertility preservation is an increasingly important issue in pediatric and adolescent healthcare, as most malignant diseases these days are curable. Mature gamete cryopreservation is the most reliable, successful strategy for fertility preservation when embryo freezing is not practical. And all these adolescents, in them, embryo freezing is otherwise also not possible because most of them are not married. In addition, ovarian tissue cryopreservation is an effective option for female fertility preservation, though there is room for improvement in its efficacy. Autograft of immature testicular tissue is currently the most promising method for prepubertal males, but still it is in experimental stage. There is need for good government-funded fertility preservation program in our country. So at the end, I would like to thank you for the patient hearing, and I hope the talk has been helpful to you.
Thank you, dear, for such a nice and elaborative talk. I think it is more important for transgender persons rather than oncology treatment.
I think
you have thousands and millions of cancer patients and very few transgender.
Yeah. So, I think cancer patients, there are many cancer patients, but biggest problem is the financial. In our country, financials are biggest problems, and we don't have any institutions. So once we have those institutes who are really geared up towards the treatment of these cancer patients, and at the same time they have attachment with the fertility preservation institutes, then only it will be possible. So, and this should be all, I think, centralized. There should be one referral center, one tertiary center where all these things can be done. So maybe even in India, if there is only 1 or 2 centers, that would be great. So I think that is the need for our country.
More than that, I think it's the insurance which should, we should work towards getting insurance for fertility preservation for all these various reasons. So that is really going to help us in increasing the number of patients, because what happens in any of the patients that who are going to undergo transgender surgery, endometriotic surgery, or cancer surgery, they're already spending for that.
So
And
much. So,
you're having the cost for fertility preservation unless you do it free of charge for them. Like I don't take money for this thing, but they have to at least pay for the drugs. I don't take anything for
I
the
have had 3 ICSI pregnancies for males who had cancer, and they had before taking chemotherapy they had cryopreserved the semen sample, and then we did ICSI and these patients.
very easy, Asha. But if you talk about IVF and for a female patient, they have to spend such a lot because they have to spend for the
Yeah.
So
Yeah.
basically, it is the insurance only which is going to help us. So
Madhuri, insurance for ordinary patients to get IVF is so difficult. So where we are talking about adolescents
they
and
won't, no, they should give not for ordinary, but for these patients because this is indicated. I mean, patients who are going for IVF for the other reasons is totally different, but this is totally different. I'm trying to see how I can, I've contacted a few.
I think that's very good idea.
We have seen. So one more thing I wanted to add to your talk was the prepubertal boys. So now the experiments which are going all over the world is when they do the testicular tissue, they are isolating the spermatogonial stem cells and also, and then they're transplanting back, but they're also doing a organoid generation. So there are different methods of generating the organoids. So they have been able to produce sperms from the prepubertal boys, developing the organoids. Though there have been no pregnancies, they have not retransplanted them into the testicular tissue of the after they become they have attained puberty. But these tests are going, these experiments are going on, and probably if they are successful, then probably it would be really helpful for the prepubertal males, because in females they have established even pregnancies after they've stored prepubertal
ovarian tissue transplant.
Very true. And ma'am, Bakshi ma'am, I totally agree with you that unless we have such a huge amount of money being pumped into cancer institutes, nearly every middle and big level city has got cancer institutes, semi-private, government. So if these are attached to fertility units, then the things can become very much streamlined and some fund can be generated for fertility preservation also.
The cancer surgeons or the medical oncologists are not really willing also to refer the patients for fertility preservation, because there are so many patients who come to us and then we advise them, but then they just go back to their oncologist and the surgeon says, no, you have no time and all. Though we have today's random start protocols wherein we can start protocol at any time, ovarian tissue cryopreservation, but the awareness among the oncologists, both medical as well as the surgeons, is very, very less, and they're not willing to accept that time period even of 2 days when you're doing an ovarian tissue, or of 10 or 12 days when you're doing an oocyte or an embryo cryopreservation.
Yeah, Madhuri ma'am. Actually, that is the basically reason, and it's awareness. We should tell our colleague oncosurgeons and that. Yeah.
That's why our mission today. So whenever we are doing CMEs via for FPSI all over the country, and we are inviting the oncologists and oncosurgeons. So they're part of all our panels, what we do. And we also tell them to give a talk, and then we do basically case-based discussions. So we allow them to understand that it is very, very essential. And this recommendation, whatever I told you, which we have published from the Fertility Preservation Society, is after we have visited 11 cancer hospitals, and then we have taken their opinion, and therefore at the end of everything, whatever the international guidelines are, we have written what is the Indian context and what we should do further to improve the fertility preservation.
And nowadays, madam, insurance people are coming a lot, so I think insurance is also a very good part which you have touched, Madhuri ma'am. So they should people should come.
Ma'am, what I think that fertility preservation in India, of course, the financial issue is there. So the NGO who are funding the cancer treatment should also fund the fertility preservation in those patients.
They are also not made aware of the importance. Now they give more importance to the cancer treatment rather to fertility preservation. They're not looking at quality of life post-treatment. So they are, though all of us know now today that the quality of life is improved, plus the survival rate has improved quite a bit all over the world and even in India.
Thank you, ma'am. Thank you so much, Asha Bakshi ma'am, for such a wonderful talk. So now let's move forward for our next session. So our next session is by Dr. Suma Varsha Madam. And Madam is the winner of Dr. Jaideep Malhotra Yuva Orator 2024 in the ISAR conference, which was held in Bhubaneswar. And, the topic is fertility preservation. Today, the need is real. And the chairperson of the session is Dr. Monica Singh Madam. And Madam has already been introduced, and Madam is the convener of this webinar. So over to you, Monica, ma'am.
Thank you, Dr. Purnima, and it is a pleasure to welcome dear Dr. Suma to our program. In fact, when we met in, I think, Jaipur, that was the time we started talking about this. And we are very proud of her. She is the winner of this Jaideep Malhotra Yuva Orator Award. The last year it was given to a person, Dr. Santosh Jaina, who spoke on AI. And this year, Dr. Suma has won it. And a very contemporary topic. She is an upcoming and dynamic gynecologist belonging to Vijayawada. And she was a former assistant professor at SBI MS Tirupati. She's the Joint Secretary of Andhra Pradesh IFS, and of course, the winner of Jaideep Malhotra Yuva Orator Award 2024. We welcome you, Dr. Suma, and the stage is all yours for your talk.
Thank you, ma'am. Thank you so much for the kind introduction. I'd like to share my screen. So I thank Monica's ma'am for giving me this wonderful opportunity. I'm extremely humbled to be sharing the platform with so many stalwarts in this field. So I hope my screen is visible. Can I start?
Yes, it is.
Yeah. So reproduction is the essence, or it is required for persistence of life, and it is the right of every individual. But there are certain circumstances where individuals who are potentially fertile may become infertile when they face certain obstacles. So I'm just going to quote a few examples. Mr. and Mrs. A were devastated when they realized that their 16-year-old son was diagnosed with lymphoma. As they were getting to terms with the diagnosis and were figuring out the treatment options, they were taken aback to know that at the end of treatment, their son may end up becoming sterile. So life was very beautiful for a 26-year-old Miss B, who was at the peak of her career. She was about to kickstart her journey in her dream company, and but her excitement did not last long when she was diagnosed with breast cancer. And who would marry a girl who is battling cancer and who would also end up becoming infertile? So Miss C was a 20-year-old student. She was facing an autoimmune condition called SLE. As the regular medications, immunosuppressants were not working, she was prescribed some chemotherapeutic drugs, which would eventually deplete her ovarian reserve. And she was also staring at infertility right at its face. So Miss D was a 26-year-old, recently married. She was diagnosed with melanoma. This put a full stop to all her aspirations of a fairy tale married life, and she was also probably facing a condition which could render her infertile. Miss E was a 30-year-old model. Marriage was not on the cards in the near future, but she always wanted to have a family when the time was right. Now, these are just a few examples of people from different walks of life. Be it a child to an adult, married to unmarried, limited by disease or living by choice, who wanted to preserve their fertility against the threat of age or disease. So fertility preservation now has opened up avenues for many such people. It is the application of medical, surgical, and laboratory procedures to preserve the potential of genetic parenthood in adults and children at the risk of sterility before the end of reproductive lifespan. So it is not just indicated for oncology treatment, be it surgery, chemo, radiotherapy, but also in certain benign conditions like bilateral oophorectomy for BRCA positive patients, surgery for severe endometriosis, chemotherapy for autoimmune conditions, genetic problems that lead to premature ovarian failure like Turner's, Fragile X, and azoospermia and Klinefelter's. And social egg freezing has gained a lot of importance these days with increasing modernization. And now a woman has the right to choose when she wants to embrace motherhood. So the war on cancer has been an aggressive one. And as per the National Cancer Registry of India, 1 in 9 people are likely to develop cancer. And 1 in 530 people between the age of 20 to 39 years is a childhood cancer survivor, which is a staggering statistic. And cancer now is no longer an acute death sentence, but it is a disease where people actually survive for an extended period of time. So their quality of life matters. And for these cancer survivors, fertility is the next major concern, second only to mortality. So this really emphasizes that fertility preservation is extremely required in the present era. So the 5-year survival rates of cancer in India has largely increased, and this is mainly because of early detection, newer chemotherapeutic drugs, and more aggressive radiotherapy. And as the survival rate of these patients increase, the need for fertility preservation is further re-emphasized. So fertility could be compromised either because of a surgery, which could be where you have to remove the gonads and gynecological malignancies, or it could be because of chemotherapy. Non-cell cycle specific are more damaging, alkylating agents being the most gametotoxic. Cell cycle specific at least would spare the resting primordial follicles, unlike the non-cell cycle specific. Radiotherapy also causes depletion of the fertility. Total body radiation or pelvic radiation can damage the gonads. Cranial radiation impairs the hypothalamic function, which could cause hypogonadism. And the effect of radiotherapy is also seen on the uterus, which can undergo fibrosis, and you may not be able to get a proper endometrium, which is receptive. So as per the American Society of Clinical Oncology guidelines, which were first formulated in 2008, and it has been updated recently in 2018, healthcare providers caring for adult and pediatric patients with cancer should address the possibility of infertility as early as possible, even before the treatment starts, because that is the ideal time where we should do something to preserve their fertility. As already addressed by Madhuri Madam, there are various barriers to fertility preservation at different levels, be it at the level of the patient, at the level of the provider, or at the level of the institution. So this particular study shows that healthcare providers were not even aware of the need to discuss fertility preservation. So as rightly pointed out previously, most of the oncologists don't even discuss it because they don't know their role in discussion. And raising awareness on essential components of fertility preservation discussion by checklist or an algorithm may help in addressing ambiguity and promoting consistent fertility preservation discussions by healthcare providers. This is a study which showed that the information given to patients and the parents and the hope for future parenthood positively impacted their decision to preserve fertility. So many times they are not even offered fertility preservation. They are not even told about the life expectancy and the quality of life beyond cancer and what all options they have for fertility preservation. And that information actually made them take positive decisions. So what are the options? It could be a conservative surgery in ovarian and cervical cancers where applicable, as already stated by ma'am. Radiation therapy, you could go for pelvic shielding or ovarian transposition. Chemotherapy, GnRH analogs can reduce the effect of chemotherapy, but cryopreservation is largely the foolproof method for fertility preservation. You could go for oocyte preservation, sperm cryopreservation, embryo or ovarian tissue or testicular tissue. Now, the choice of tissue depends upon the age of the patient, the availability of the male partner, and the time available before the start of their cancer treatment. Embryo and oocyte cryopreservation has been the standard of care, and now with newer stimulation protocols, we can reduce the time required for this fertility preservation technique. And in hormone-sensitive breast cancers also, we have certain modifications like the natural cycle, and sometimes we can use some adjuvants like letrozole to decrease the effect of estrogen. Ovarian tissue cryopreservation, which was previously experimental, now ASRM has removed that label of experimental and now it is validated. Fertility preservation in the males in the pubertal group remains quite good, but in the prepubertal group, it is still quite a challenge with only experimental being in the experimental stage. Social egg freezing has now gained a lot of importance. There's a lot of social media attention being given with a lot of celebrities endorsing to social egg freezing. And now the woman's life is always limited by the continuous ticking of the biological clock. So giving an informed choice of social egg freezing whenever she wants to postpone her pregnancy is always required, and it is the need of the hour. So we know that as the woman ages, her ovarian reserve keeps getting depleted. At the age of 30, only 12% of the eggs remain. And at the age of 40, only 3% of her reserve remains. Apart from the depletion of ovarian reserve, there is also a significant increase in the risk of aneuploidies as the age increases. So at the age of 30, the frequency of Down syndrome is 1 in 900, which increases to almost 1 in 100 at the age of 40. So for any woman who wants to really postpone her pregnancy, these statistics will really help her make an informed choice where she can preserve her oocytes at a certain age and then decide when she wants to get pregnancy. So various causes or various choices have been put forward for the need for egg freezing, be it career-oriented decisions, be it education, be it not finding the right partner, be it the partner not willing for pregnancy as yet. So for various reasons, so social egg freezing has taken a lot of importance these days. So, but there are certain words of caution because sometimes we may just be giving false hope to postpone pregnancy. And later on, if the cycle fails, the patient may be left with no reserve for a second chance. Collecting sufficient number of eggs to target a live birth, there should be a consensus on this, but approximately around 15 oocytes should be cryopreserved. And long-term studies on health risks associated with cryopreservation need to be established. Stem cells differentiating into germ cells should be the way forward, which could replace the preservation techniques and the need for gamete donation. But currently, it is not the mainstay of treatment and requires further research and rigorous clinical trials. We need to bridge the gap. There's a lot of information gap. The oncologists lack information. There should be more and more onco-fertility discussions, more and more panel discussions where we exchange information from the fertility perspective and they give us information on the oncology perspective. There's a lot of data gap because there are so many chemotherapeutic regimens. These have been used in different age groups. So comparison of data is quite a task. And option gap. So discussion with the patient, giving them the right options to help them make an informed choice is also something which we need to look into. So there are various societies on fertility preservation, the International Society of Fertility Preservation, Fertility Preservation Society of India, Oncofertility Consortium, and all of these working together to develop registries to collect data on fertility preservation, and the outcome of the fertility preservation is the need of the hour. So Mr. and Mrs. A opted for semen banking for their son. Miss B and C went for oocyte cryopreservation. Mrs. D opted for embryo cryopreservation. And Miss E opted for social egg freezing. So together we should all join hands to empower people to take charge of their lives. So thank you so much for your patient listening. Thank you, Monica ma'am, for having me here.
So Suma, today we all realize why you got this award. This award, this talk is an award-winning presentation. The slides are so beautiful. You spoke so nicely, and the cases were so relevant. And a big applause for you, Suma.
Thank you,
and Nandita ma'am is here with us now. And madam, if you had heard Suma, you must have seen ma'am.
Ma'am has heard me thrice. I'm so sorry to see this.
She speaks very well, and I loved her talk. Yes.
Yes, ma'am. So we welcome Nandita ma'am now amongst us, and Madam Dr. Kavita Singh is there to chair the session as your chairperson. She's HOD NSCB Medical College Jabalpur, as well as president of all MP Obs-Gynae societies. But ma'am, she just had a dental procedure because of which she's having a lot of discomfort. So I'm going to, Purnima, can you introduce Dr. Kavita ma'am for us?
Yes, ma'am. Thank you so much, ma'am. Dr. Kavita Singh, madam, is currently President MPOX and President MP SCAG OI 23 to 25. She's professor and HOD of NSCB Medical College, Jabalpur. She is having experience of more than 2 decades, and she has been president of Jabalpur Ops Gynae Society, secretary MP State MPOX, and organizing secretary MPOX. And she has received various awards and has 39 publications into her credit, and she has authored various textbooks as well. We welcome you, madam, today on this platform. Thank you for joining us. We understand that you are not able to introduce our speaker. So, Dr. Ritu Jain, madam, because of some circumstances, madam is not able to join us today. So I would like to hand over the session to Monica, madam, for the introduction of Nandita, madam. Thank you.
Thank you, Dr. Purnima, and thank you, Kavita ma'am, for being here despite your, pain. You are there with us for the session and for our webinar. It is my extreme pleasure to invite and introduce our past President Foxy, President ISAR, President IAG, MOGS, you name the body, and madam has headed it, has presided over it, and taken it forward. She is honoris causa fellow from RCOG and an eminent IVF specialist of India. She has got chains of IVF centers all over India. She is an avid teacher, orator, author. Plus, she's heading not only FIGO committees, but also several state and government-led projects which deal with PCP&DT, transplant of uterus, surrogacy, and is always willing to help all the practitioners in India who need her advice and help. Madam, we are so blessed to have you amongst us. And despite being busy in OT, madam has reached home and she is here to deliver her talk on the clinical aspects of fertility preservation.
Thank you. Monica, I'm going to share my screen because I have reached home now. So
Okay,
I can, but thank you. It's good to see Madhuri, I think. Madhuri, hi, Madhuri. Lavanya is also here. Manisha, I can see the screens. Purnima. But today I'm really happy. Hi, Fessy. Today I'm really happy to be here. But before I start my talk, I want to just tell everybody, welcome to AICOG Mumbai 2025. I always forget at the end of my talk. I think as a chairperson, I would like to invite all of you all, and it's going to be a great show. In fact, we had a meeting on last Tuesday, and there were like 75 people in our committee, and it was really, everybody is all fired to do it. So you will get a warm welcome. Hi, Asha, how are you? Good to see you. I'm going to just share my screen so that I can, I learned something new, but I didn't adjust my slides according to that. But next time you'll see something funky in my presentation. I didn't have time today. Thank you, Monica.
Your presentations are always so funky, Nandita. I admire your presentations. They have got the 3D effect.
This is something totally different. One second, I can't get.
It's a keynote, na, ma'am. So
yeah, no, I need to reduce this, your okay, that I wanted to reduce. Okay, now I can start it. Where is the play? Here. No. There's something really different about Zoom which we can utilize. I learned it on Women's Day, Women's Empowerment. So today I'm going to talk about a technology called fertility preservation, evolution to excellence, and empowerment of women. I hope I'm audible. Yeah.
Yes.
Okay. Yes, ma'am. Yeah, my mute is off. Yes, thank you. So this is a technology which has, changed lives. When oral contraceptive pills came in the late 1800s, early 1900s, it gave empowerment to women because the women were able to control their own reproduction. Otherwise, they were just delivering babies by the dozens. So it was one of the biggest disruption. And now, trust me, fertility preservation is another big disruption in the world, and it has given empowerment to women. And I think we should educate our women about what is available. So what actually changed the scenario? We've been doing preservation for a long time. But what actually changed was the change in technology from slow freezing to vitrification. And that was unbelievable because it really, revolutionized the whole thing. When we froze 10 eggs, we got 10 eggs back. And the old system was so not that efficient, that if we froze 10, we got 4, 5, 6 back. So it was that efficient. There was so much damage. So I think that is definitely changed everything. It's a remarkable milestone. And reproductive capacity, we know, is seriously affected by age, different medical conditions, and also by treatments. And remember that there was a study which said that Indian women age 7 years faster than the Caucasian counterparts. I think this is also something that we must remember. And there is a general consensus to provide counseling about all the currently available family fertility preservation options to all individuals wishing to preserve their fertility. In fact, there was a study in 2018 which actually said that hardly 10 to 30% of the women were aware. Those who were married were aware of fertility preservation, and those who were not even married didn't have any idea about this technology. So I think we need to have a futuristic vision, which these two girls had. And Diana has got 3 babies out of eggs which were frozen when she was 33 and 34 years old. Ekta has 1 baby out of the eggs which she had frozen when she was 33 years old. And I think the fact that I put these 2 pictures is because these girls have been very vocal about fertility preservation. They've come out in the open, they've talked about it, and they've encouraged people. And we know we always need brand ambassadors to do this kind of work, and that is what is important. And let me tell you the story about Diana. When she came in 2007, just before her, one very famous personality had come to me in October, and we did embryos freezing, and we had 10 embryos. And we did it with slow freezing. And in December, Diana came and we had vitrification technology. That girl has got only 1 baby out of those 10 embryos which are frozen. But Diana got 3 babies out of her eggs which were frozen. So, because the slow freezing versus vitrification, that is a technology which made a difference. And I'm sure, Madhuri has spoken about it. So I'm going to just touch the clinical aspects. So biological clock keeps ticking. And what can we freeze the fertility for? I think social reasons, like they don't want to get married, or they've not found the right partner, or a lot of mothers came to me, bringing their daughters, that she's going abroad for education. By the time she comes back, she'll be much older. So let's freeze her eggs. So it was very forward thinking. But some of the mothers are like that. Today I got a patient where the girl came to me and she said it took 1 year to convince her parents. And her mother had come with me. She had so many questions to ask. But remember one thing, in India, what I insist on is that the parents should be involved if they're unmarried girls, because they need to understand, they need to be explained. And I think that is very, very important. Then, of course, we are seeing a lot of patients with poor ovarian reserve. In those cases also, we can preserve the fertility. Iatrogenic poor ovarian reserve, because of surgery on the adnexia, if we can it can happen. Poor ovarian reserve because of gonadotoxicity. Then genetic causes, which I'm going to elaborate on the next slide, but autoimmune disorders, neoplasia, chemotherapy, radiotherapy, bone marrow transplantation, all these conditions we can offer fertility preservation to the girls. In fact, the genetic conditions which are commonly seen as, a young girl comes with breast cancer, or a family history of breast cancer, and the girls undergo a prophylactic salpingo-oophorectomy. They are advised because of BRCA1 and BRCA2, and they can preserve their fertility before going in for this prophylactic salpingo-oophorectomy. Then, of course, Turner syndrome, deletion of X syndrome, fragile X syndrome, all these patients come with a poor ovarian reserve. So if they don't want to have a child, you need to preserve their fertility, because they will land up with premature menopause for sure. So fertility preservation counseling is very important, because you need to tell them fertility preservation does not mean 100% you'll get a child, but it's like a chance that you will land up with 60 to 70% chance of having a child. And today, with the artificial intelligence technologies that we have, we can definitely guide them regarding it. Then, of course, you should also tell them that oocyte donation is an option in case they don't want to do fertility preservation. And of course, adoption should also be discussed. So the process is simple. You have ovarian stimulation. And today, because of Bayer and Pearson's work, we know that there are 2 or 3 follicular waves during one menstrual cycle. So that means previously, which we were taught that there's one wave and you recruit those eggs from that wave. No, but each patient has 2 waves at least. And 30% of the patients have 3 follicular waves. So you can do stimulation at any time. It's very important for especially cancer patients when we don't want to waste time before their cancer therapy takes over. So yes, you can do early and mid follicular phase stimulation. So any time during the cycle, we can actually do stimulation. And the stimulation protocols that we normally use are antagonist protocols with high doses, because these patients generally have a poor ovarian reserve. Of course, those who come for social reasons, you have to assess the ovarian reserve by doing an AMH, serum AMH level, and an ultrasound which does an antral follicle count. And then depending on that, start the stimulation on day 2 with usually an antagonist protocol, because we like to use a GnRH analog trigger in these girls, especially if the AMH is very good, their PCOS, or even if they produce more eggs. So I think this is the protocol. And Letrozole gonadotropin protocol is commonly used for breast cancer patients, but antagonist is the one which is used. Now, egg freezing procedure is very simple. Egg retrieval is done. Egg denudation is done between 2 to 3 hours. And then cryoprotectant after 15 minutes of denudation, slow freezing or vitrification, storage, thawing, and storage is done. Then when we want to use them, we do thawing, and then we do ICSI after 2 hours with the spindle view. Spindle is the one which identifies where the chromosomes are in the oocyte. See, usually when these patients come back to have a child, it's a limited resource which we have. So we don't want to damage even that 10% of oocytes where the spindle is skewed. It's not at the usual 6 o'clock position or the 3 o'clock position. And then when you do ICSI, you can injure that spindle and that egg becomes useless. So using a spindle view really helps in in saving all these eggs. Then, of course, we do laser hatching prior to embryo transfer. And I'm sure, as Madhuri has said, I just want to say one word. Vitrification, the temperature drops at minus 25,000 degrees per minute. Whereas in slow freezing, you can see that, the follicle comes, the temperature drops and it stabilizes and it drops over a period of 120 minutes. So this is the difference. And what it does is this ice formation. So in slow freezing, there can be ice formation. And if you see the picture on the right with the spindle, which is in the green, and the red are the chromosomes, which are aligned on the spindle. And you can see the ice formation will actually damage the spindle. And so it's very, very important that, there should be no ice formation. But the only downside, as I'm sure, which has been told to you, is the high concentration. But let's come to the artificial intelligence which we are using in our clinical practice. Artificial intelligence uses a special camera, and that can be used before. So we do it before ICSI or even during ICSI, it can be used. But what is the importance of artificial intelligence? It evaluates and predicts the good outcome of the oocytes prior to freezing them. And this is what we've been offering for the last, I think, ever since COVID came in. So 5 years to our patients, and it actually gives a live birth rate per oocyte, and the live birth rate after freezing all those oocytes. So I think it's important. And also, if you do AI and you see bad quality oocytes, you can offer all, you can do additional things like oocyte activation using the calcium ionophore, or in case of negative prediction prior to IVF ICSI to improve outcomes, especially in poor responders where we have less eggs. So this is how the report comes. As you can see, the first oocyte has got a very poor score, likely, and it goes from 0 to 100. So probability of reaching a blastocyst is 33% with the first oocyte, but the second oocyte is much better in the diagram, and 53.2%. And this program, I don't have that image, but even the live birth rate can be predicted, and this is the artificial intelligence tools which we are using. Egg freezing record at our Bloom IVF, the total number of donor oocytes frozen at Leelavati Hospital from 2007 to 2020 is 17,228, and the social egg freezing is 7,098, and the fresh donor cycle success rate is 56%, and the thawed donor cycle oocytes, the thawed donor cycle success rate is 64%. So this is to just show you that freezing and thawing does not affect the pregnancy rate where oocytes are concerned. So this is a very important thing which everybody should understand. But of course, it is the skill. Immense skill is required, though now there are robotics and you can automated oocyte freezing technologies have been introduced. In fact, I saw one in ASRM this time. And the only thing that we worry is, supposing something goes wrong, then the entire batch of oocytes, will get ruined. But of course, I'm sure it'll become foolproof, safe as the time goes by. So remember, what is most important is age, because according to age, the number of oocytes which give at least one euploid embryo changes. So if your patient is younger than 35 years, it is 4 eggs gives one euploid embryo. So definitely more oocytes, you get better results. In fact, there's a study by Anna Kobo et al. Where she says if there are between 10 to 15 eggs in under 35, the pregnancy rates are as high as 70%. Live birth rates, not even pregnancy rate, live birth rates. So 35 to 37 years, 5 eggs will give one euploid embryo. 38 to 40, it's 7 oocytes. 41 and 42, it's 10 oocytes. But the minute you cross 42, you become 43, 44, 45, it is 20 oocytes. In fact, today I had one patient, 46-year-old, who said, I want to use my own oocyte. So after I counseled her, the chances of Down syndrome, the chances of abortion is 50%. Then, and the success rate, I said nothing above the age of 45. There's been no that they have conceived with their own eggs. I offered, of course, ovarian rejuvenation and other technologies, but then finally she went for egg donation. But remember that there are other causes like what we do, cystectomy. I think cystectomy in an endometrioma really damages the ovarian reserve. Meta-analysis have shown that. And also remember that if you use laser and if you do stripping first, and at the hilus are the maximum number of oocytes. So if you just cut off the cyst wall over there and just cauterize it with laser or cautery, I think it really preserves the embryos. This is the Dornay technique, which he introduced in 2012. Then, of course, the impact of excision on ovarian reserve, a systemic review, which was published in 2016, 367 patients from 10 studies showed that a significant decline in serum AMH level after ovarian cystectomy. Ovarian cystectomy can be done for simple tumors, for ovarian cancers, and for endometriosis. But endometriosis has the worst effect because it reduces the ovarian reserve. And of course, in cancers also, the ovarian reserve is much lower. Recurrent benign ovarian tumors like dermoid, endometrioma, or seromucinous cyst. Remember, in these patients, an oocyte accumulation strategy is proposed. So you can do multiple pickups and get more eggs, because you saw that the numbers are very important, as I mentioned before. Then, of course, tuberculosis in our country is very, very common. In fact, a lot of times when the AMH is low, we look for tuberculosis in those young girls, because that can cause a low AMH. And this was a study conducted by Malhotra, who said that the ovarian reserve was compromised. Of course, he did the AFC, but also a study by J.B. Sharma says that if you give AKT or anti-tuberculous therapy, the ovarian reserve actually improves. So this is something that we can offer our patients. If we move to fertility preservation in cancer patients, I think, remember that if there is less than a week left for your treatment to start, you can use GnRH agonist to protect the ovary. If you have less than 2 weeks, you can actually do stimulation and preserve the oocytes. If 3 weeks, double stimulation can sometimes be done. In one cycle, you can do dual stimulation. In 1 week with low risk of metastasis, then ovarian tissue freezing can be offered to these patients. 2.5 weeks with low risk of metastasis, freezing plus stimulation. So you can stimulate the ovary, get the eggs out, and then remove one ovary and freeze it if required. And radiation therapy, you do ovarian transposition. So these are the different ways of ovarian preservation techniques. And remember that I always keep this chart with me. These are the drugs with the highest risk. So 80% chance of amenorrhea with, cyclophosphamide, busulfan, etc. So this risk, I don't remember, but I keep it in my clinic, which tells me. So very low risk or unknown risk or even low risk, these patients, you need not tell them to go for egg freezing, because they will respond and they will. But of course, everything depends on the age. If they're older, it is advisable to do egg freezing before taking the low-risk therapy also. And the risk of metastasis is important, especially if you're freezing the ovary. The lowest risk in breast cancer, infiltrating ductal subtype, squamous cell, Hodgkin's lymphoma, osteogenic carcinoma, Wilms tumor, and non-genital rhabdomyosarcoma. The highest risk is in leukemia, neuroblastoma, Burkitt's lymphoma, and ovarian carcinoma. But today, you can offer ovarian freezing to any patient, because even in the high risk, there are new technologies which have come where you take only the primordial follicle from that tissue and seed it onto a 3D built ovary, and that ovary starts producing, oocytes. So there are lots of things available. So don't lose the opportunity to freeze whatever you can get. I think that's very important. You don't know 10 years down the line, something new will happen. Of course, 10 years down the line, we'll probably make oocytes from the skin cells. But even radiotherapy, this is another chart which you keep with you, and you can understand how the ovary is affected. Autoimmune disorders. Now, a lot of gonadotoxic therapy is recommended in young women, and that's why ovarian stimulation and cryopreservation of eggs is definitely recommended in these women. But remember, thrombosis prophylaxis has to be considered in these patients. Then, of course, the ovarian outcomes in women transplanted with cryopreserve, not 20 studies, 40 patients only, but what is the live birth rate? Overall pregnancy rates varied between 3.9 to 19.3%, and live birth rates from 3.9 to 14%. So yes, the pregnancy and live birth rate in women undergoing ovarian tissue transplantation and ovarian cryopreservation, ovarian OTT and ART were definitely lower of the as compared to IVF patients for general causes, but they were equivalent to poor responder patients. So that success rate is similar. In general, ART outcomes are underreported, and there's a lack of consensus regarding the timing of ART in relation to OTT and the type of ovarian stimulation protocol. So that has it in leukemia, remember that you have to be very, very careful. The most assuring data is autotransplantation safety was found in lymphoma patients. But remember, what about children and adolescents? This is a systemic review, 91 studies, 1,000 patients, and ages were 0.4 months to It's 0.4 years to 20.4 years old. That means 4-month-old babies also. And 20 patients aged 13 to 20 underwent successful oocyte harvest. But the younger ones, the 37 patients, underwent oocyte transposition, and 18 patients underwent autotransplantation, resulting in live births. So fertility preservation options are available to girls under 20. What are they? Oocyte tissue cryopreservation for those who cannot be stimulated, then oocyte cryopreservation and ovarian transposition. So these three options, and today OTC is officially allowed as a method. It's no longer experimental. Of course, there are experimental fertility preservation techniques, like I said, xenotransplantation, where you transplant the ovary into another species and then do stimulation and remove the oocytes, or in vitro growth, where IVM can be done. Isolated follicles can be taken, and artificial ovary, which I talked to you about, that we can take these primordial follicles and seed them onto this matrix, the 3D imprint of the ovary, which is made, and the granular cell, the theca cells, and the stromal cells can be implanted, and primordial follicles can be grown into follicles. But of course, no application in the human system as yet. Then alloderm is a decellularized human extracellular tissue matrix. And, the ovarian tissue, when you put it in, it takes longer for vascularization. So a lot of the ovarian tissue is damaged, nearly 40% gets damaged. So when you use alloderm, this damage is reduced because the vascularization is faster. And Octave, who's done a lot of work, has published a lot of studies in it, and it is used. So finally, I would like to end my talk by saying, remember, friends, life exists after cancer. Because in our country, there's no counseling, there's no, people are devastated. So that fertility counseling is very, very important. And this needs to be told to the patient. Then fertility insurance, like the life insurance, it's not 100%, but it definitely works. Then fertility focused to pelvic surgery needs to be integral to training so as to protect the ovarian reserve. And one of the studies which it got missing from Anna Cobo, published in 2023, that the live birth rate of fertility preservation is nearly between 40 to 70%. So yes, the younger you are, the more oocytes you get, better is your chance. And today, you know what? The artificial intelligence tools actually help patients to make a decision. You tell them, look, this is what the live birth rate is showing. So definitely you need more oocytes to improve your live birth rate. And that absolutely helps. So use technology, use everything to empower your girls. I think it's very, very important. And especially on the occasion of International Women's Day, I think this is a technology which should become widely available to everybody. So thank you very much, Monica.
Thank you, ma'am, for that beautiful, beautiful talk, ma'am. I know you.
Thank you, ma'am. Yeah.
Thank you.
You speak about all the practical the things you've actually done and the celebrities you have dealt with. So we know every particular example you're giving us is like, lifelike and true, the real life examples. So, ma'am, thank you so much. Thank you so much for that wonderful talk. And I'm very grateful for you to joining, ma'am, despite your hectic schedule today.
No, I'm not an obstetrician, but one of the days I do get an emergency.
Madam, every time you have an emergency, Nandita ma'am, I have that somewhere I'm in the periphery.
Oh my God, that means yours and mera grah shanti karna chahiye.
Monica, she is a busy person, but she knows how to manage the time. That is most important. So she's always busy, but she manages time very well.
Yes.
Thank you, Asha. Thank you.
And I've learned few tips from you, so I know.
Anita, madam, 2 weeks earlier we went to Allahabad, and Allahabad, ma'am, and Dr. Rishikesh Pai sir has given that information which you gave just now. Artificial in AI helps you to sum up how to improve the results and which are the best ones.
I think it really works well. Thank you. I have to run to another seminar.
Okay, thank you, ma'am. Thank you, ma'am. Thank you,
Thank
ma'am.
you.
Bye.
Bye.
Thank
Bye.
you, ma'am.
Thank you, ma'am.
Thank you.
There is a slight change in the program of the panel because Dr. PM Gopinath had some, other commitments. So our panel discussion now is being taken by moderator Dr. Madhuri Patil ma'am with expert Dr. Fessy Lewis sir. And there might be some changes in the questions, but I'm sure our panelists have been there. They've listened to all the talks and they'll do a wonderful job. And joining the panel is also the brilliant Dr. Purnima Tiwari.
Thank you, ma'am. Emergency situation. So now let's move forward for our panel discussion, and I would like to hand over the session to Dr. Manisha Jain, madam.
Thank you so much, Dr. Purnima, and feel delighted to be part of this very, very great webinar today with such great stalwarts. So now we move on to the next panel discussion, which is on fertility preservation in real case clinical scenarios. And as Madam said, there's a change in the program. So we have with us Dr. Madhuri Patil, Madam, as the moderator. And Madam has already been introduced earlier. And the topic expert today we have is Dr. Fessy Lewis, sir. Can we have a CV? Sir has also been introduced earlier. Sir is not, Gopinath sir is not. Can we have the CV of Madhuri, madam?
No, not required. Yeah, CV again.
Okay.
Panel members go.
Okay, so we go ahead directly to the panelists today. Out of 10, I think we could just 4 of us panelists could join us today. The first panelist is Dr. Jigyasa Dhingra, I think. Can we have the CV of Jigyasa? Dr. Jigyasa is a very eminent and lead consultant, IVF consultant from Jabalpur Open Society, and she's the joint secretary of Jabalpur, a very academic, very member of the society. She has various publications and has been the national and state faculty to various conferences. Welcome, Dr. Jigyasa. Next, we have with us today Dr. Lavanya Kiran, madam. She is again a very eminent consultant and gynecologist. She has received various trainings and awards, and she is a great robotic surgeon from Bangalore. She has received various trainings in regenerative medicine, cosmetic gynec, endoscopy, and has been considered by the Karnataka Commerce and Industry Association for his contribution to women's health. Welcome, Dr. Lavanya.
Thank you, ma'am.
Next, we have with us Dr. Varsha Khandelwal. She is again the secretary from Nardamar Housing Society, very active member of the society, consultant at Khandelwal Sonography Laparoscopic and Infertility Center, and has immense experience of more than 2 decades. And she has presented various papers.
Is Varsha there? I can't see Varsha.
She was to join, ma'am.
No, she has not joined.
She's not.
Ma'am, she said she's there, probably with different name. I'm just asking, ma'am.
No, I'm seeing everybody who has joined. So I think is Varsha there? If she can speak out, otherwise we move to the next panelist. Let us not waste time. Okay. I think you introduce the next panelist, Manisha.
Next, we have the
Dr.
next M4
Suma madam
panelist
is
today,
there
Dr. Purnima Tiwari.
And Dr. Suma madam.
Who is the coordinator of the program today and consultant at Apollo Sage Hospital. Very active and very dynamic consultant. Dr. Purnima. And next we have Dr. Suma, ma'am. We recently just listened to her. She has a. Can we have a CV?
Yeah, that's okay. You just introduce.
Okay, madam was just introduced.
Has been introduced. Manisha, now let us not waste time. Madhuri ma'am has been there long
hand
time.
over to the panel moderator, Dr. Madhuri madam. Over to you, ma'am. Thank you so much.
Ma'am, at the outset, I'm very grateful to Madhuri ma'am for overcoming this emergency situation for us and taking over the panel. I'm sure we are going to have a great time with her today.
So first we'll go with simpler cases. So we'll go with endometrial cancer. So we know that the prevalence is rising in women who are younger than 45 years. And therefore, though the Standard care is total hysterectomy with bilateral salpingo-oophorectomy. And we know that the maximum risk factor includes PCOS and anovulation. And today we know that obesity, diabetes mellitus, and hypertension associated with PCOS also play a high role. And those with these complications are at a higher risk. And basically, fertility sparing treatment is considered for endometrioid patients with endometrial carcinoma, grade 1, stage 1A, without any myometrial invasion and without any risk factors. And hysteroscopic guided endometrial biopsy is preferred for confirming the diagnosis. So this was a case, was 30-year-old. And if you look at her obstetric history, she had one blighted ovum soon after marriage. And then after that, she was unable to conceive. She had undergone 3 cycles of ovulation induction with clomiphene citate. And estradiol, I don't know, was added in all cycles, though the cycles were not monitored. Mother did have a history of diabetes mellitus, and her maternal grandfather had CA lung. So if you look, her BMI was 26.4. And if you look at her investigations, AMH was 3.4 earlier, which was now reduced to 2.24. TSH, prolactin, everything was normal. A1C was also normal. And semen analysis, it was 21 million, but the rapid progressive was only 15%. HSG showed bilateral spill. And if you go to look at the transvaginal ultrasound scan, she had adenomyosis. You can see that the endometrial myometrial junction was quite irregular. There were also several calcified spots here. You can see in the myometrium. The endometrium was thin, and as I said, it was isoechoic. So probably we suspected adhesions, and endometrium remained thin and then refined all throughout her cycles. So she was advised hysteroscopy and endometrial biopsy. The cavity was adequate. Multiple small polyps were present, which were sent for histopathology, and it turned out to be endometrioid adenocarcinoma grade 1. ER/PR was positive, P53 was wild, and MMR was proficient. So what is the next step in this patient? Anybody can answer. I cannot see the people who are there in the panel. So what would you do in this patient?
Ma'am, hello, ma'am.
Yeah.
Yeah, ma'am, this patient will require the counseling, and information should be given about the fertility preserving part before starting cancer treatment. And obviously cancer treatment we have to give, we have to prioritize that, but we have to counsel her and tell her.
Endometrial cancer, just grade 1. So how would you counsel her? Yeah, Lavanya?
Ma'am, since it's just grade 1, I think we can follow up the patient. We can start her on medroxyprogesterone. And then simultaneously, of course, we have to tell her that, we can start the stimulation simultaneously. We can start the stimulation for her. Go ahead and maybe repeat the biopsy in next 2 to 3 months, then take a decision. Of course, before that, I think CT and MRI would be more ideal, because here we have only the biopsy report. I think doing a MRI also would be worthwhile for her.
What does MRI tell you?
It will tell us about the myometrial invasion, because here only in the scan they have done. But I think knowing, because if it is more than 50% myometrial invasion, it is very important that we have to go ahead with the hysterectomy. So I think that is when we'll have to talk to her about, oocyte preservation, all these things. And, so I think MRI would add more value to her for the treatment.
Bessie, what is your thing?
I think usually whenever we get cases, we refer usually to our gynec onco-surgeon team. Whatever cases we got, they give Migase and for 6 to 9 months progesterone, and then repeat the sample. And if it is negative only, we'll proceed with IVF. Because since it is positive, receptor positive, it won't be nice to start a stimulation at this stage.
Yeah. So basically, we have to know that megestrol is the best progesterone, which has to be given, which is to be given better than medroxyprogesterone. When would you say the treatment is complete?
We have to get a negative sample after at least 6 months or 9 months of.
I think the first rehysteroscopic biopsy should be at 3 months.
Yes, at least usually we go for 6 months minimum.
Yeah. And then depending on that tissue there, and then it has to be 2 consecutive samples which are negative and 3 months apart. That indicates, and if there's no response in 6 months, we need to reevaluate. And if there is no response after 15 months, basically it is treatment failure and you have to subject this patient to a hysterectomy. So what is the risk of recurrence if you're doing a conservative management?
I think most of them do very well with the medical management, especially when it is grade 1. There's a high incidence of almost 80% being very good even on the second biopsy. Very few of them only become more bad. So I would also say, yeah, I understand that the megestrol is a better treatment modality. Medical management, I think majority of them do very well. So recurrence risk is as low as 20%, I would say.
40%. And basically the disease-free interval varies between 12 to 28 months. So suppose after 2 years of diagnosis and the patient does not conceive, then it is best again to go for definitive treatment of hysterectomy. So basically, even if you look at the molecular profiling, when we look at the estrogen and progesterone expression, it is basically predictive of the response in conservative treatment and is useful for patient counseling. And negative ENP expression are not a contraindication for fertility sparing treatment. Though if they are progesterone positive, I mean, your progesterone is going to have a better effect. They also do a lot of molecular profiling of early onset endometrial carcinomas and its correlation with the treatment. And they perform the PROMISE molecular classifier in all young patients with grade 1 endometrial carcinoma who wish to preserve fertility. And basically, it is, and this has a level 4 evidence and which is grade B. Immunohistochemistry is also very, very important because basically it is going to help us in identification of the repair deficient tumor, and it's mandatory in all patients, especially in patients who are at a higher risk of having Lynch syndrome, which involves the colorectal carcinoma, and in women harboring copy number P53. So these patients, usually the conservative approach should not be given. So when will you allow a pregnancy and how? Whether you should allow for a spontaneous pregnancy or for ART? Yeah. Anyway,
if nobody's taking, then I'll take. I don't mind. So post treatment, and then we have a negative report. Like after we waited, like Dr. Petra said, I think we can allow a spontaneous pregnancy for another 6 months because I see that she's only 30 years. The AMH is still okay, 2.2. Of course, she was 3.4. I noted that in 22, and the repeat was 2.2. So I think it's still good for her to go ahead and try. Over 6 months from her trial and she doesn't conceive, maybe then we can start thinking about simple methods like ovulation induction for her and not anything else more than that. Of course, it's a repeat biopsy, I would say.
Any other opinions?
In that case, I would say that, of course, we would go for ART because we have to expedite the pregnancy. She is at very high risk of recurrence again, and we have to give the pregnancy in the quickest way. So I think I would go for the ART.
Yeah, because we should see that the pregnancy happens within 12 to 24 weeks. So basically, we have to encourage her to conceive as soon as we have a remission. And because the ART is going to improve the success rate and also reduce the interval to conception without a higher risk of recurrence. And natural conception may be considered in women with good reproductive potential and a defined time that is only for 6 to 9 months, as Lavanya said. And is definitive treatment required, and when would you advise a definitive treatment?
Definitive treatment means for the malignancy or the infertility?
No, it's hysterectomy.
Hysterectomy. I think if there is recurrence, definitely you have to go for a definitive treatment. Of course, we have to counsel them the possibility of IVF. Patient can undergo surrogacy. Those options has to be given because the patient will be very much worried. Those aspects has to be discussed, and better to do the stimulation after the hysterectomy because of the estrogen positive receptor status. We have to better to do that after the, even if you are going for stimulation, it has to be after that and after subsequent further treatment for the lesion.
But the treatment is salpingo-oophorectomy, no?
That is true, but we can counsel them the option of hysterectomy and go for a IVF treatment and then proceed with this thing. But only thing, after the hysterectomy, we have to see the further the receptor status again.
So basically, normally if she has completed a family, you should go for a hysterectomy. If she wants a second child, then maintenance therapy with either levonorgestrel IUD can be recommended in these patients. So apart from megestrol, basically even in progesterone IUD is very, very important. And can you preserve the ovaries and only remove the uterus?
I would say, yeah, I think we can do it if she's only stage 1. And I think it would be a good idea because even the treatment protocol is hysterectomy, but we'll have to follow up on the ovarian regular scans, tumor markers, all those things have to be done. And with the good follow-up, I think we can go ahead and think about leaving back to you.
That's what I was telling. If we can consider and give the option of preserving the ovaries.
Yeah.
Ma'am, in that case, if we are giving her maintenance therapy, so how frequently we should monitor her?
As far as I'm aware, I think 6 months once the biopsy is recommended. So every 6 months we call them back, and then if they are on the medical management, I think 6 months once the biopsy has to be done.
No, I think it's every 3 monthly. I think it's better that you do it 3 months. This thing. So what are
only thing is that, madam, if you are some cases, if you put Mirena, levonorgestrel, then we cannot do the follow-up every 3 months. We'll have to wait for usually 6 months at least, then remove and then only do the tissue biopsy.
I don't think, because most of the papers which I have read about levonorgestrel, they don't require removal. You can just do a biopsy in the presence, unless you cannot see the threads and you feel that it could be a problem, because again you need to reinsert. So the patient has to undergo the procedure again. So if you are removing, then you need to probably again insert another one. So now you're going to go for ART, or the patient is not responding and you're going to go for oocyte or embryo cryopreservation. So basically we know that we have to look at the ovarian reserve, the age, as I've already told in my talk, and definitive surgery is this thing. And if there is a failed response or there is a recurrence, then you cannot keep on continuing with your fertility preservation by just medical treatment, which could be either megestrol, oral megestrol, or intrauterine. So here, I would also like to ask, what would be your stimulation protocol be in these patients? And how would you proceed?
It's the same patient, 30 years, her AMH is normal, and she's quite young. I think just a low dose should be good enough, I think.
What would your... No, because this is the only chance wherein, because then you're going to go for a oophorectomy. So you should at least aim at 10 to 15 oocytes. So what would your stimulation, what would your ovulation induction profile be? How would you stimulate her? So it would be not only the gonadotropin dose, you need to talk about how do you suppress her LH, what would be the trigger given to the patient.
I would like to go for a long protocol by giving because more the chance of oocyte and more uniform follicles, number of oocyte where you get will be less, will be more. And also we will get a.
She's already now because she's been given progesterone.
Okay, okay. I mean that after that, we will like to. I mean immediately after that. No, once she gets the normal periods, then only we need not be to start immediately after the progesterone is stopped. We can wait for one cycle and then start the suppression, and long protocol will be preferred.
Ma'am, I think she's already taking progesterone,
I
so
would
she's
say
already
progesterone, yeah.
down. But in that case, GnRH anti protocol we can follow, and we can give the agonist as a trigger.
Yeah.
I would also go with antagonist and agonist trigger.
What about progesterone primed ovarian stimulation?
Even though it is a new
Not tried
protocol,
much, but yeah.
not much experience with that.
Pre-period.
But we can do because basically progesterone for her to treat her malignancy. So progesterone prime protocol can be used because that is going to decrease the cost. So would you advise OTC in this patient?
I think not required because she's married, and I think that a good protocol stimulation, like you said, around 15 oocytes, if we can aim, that should be good enough for her to even plan her second pregnancy. So not really ovarian tissue cryopreservation, according to me. I think we could go ahead with the embryo preservation.
Because there is also a higher risk of involvement of the ovaries, and therefore even the ASHRAE guidelines do not recommend basically OTC. So we have already discussed the ideal protocol. So would you give letrozole in this patient to keep her E2 low?
I would have considered only if AMH was lesser, maybe then I would have thought about adding a letrozole. But since otherwise, I think response to just the gonadotropins directly would be still good enough. So,
but she's ER positive.
Yeah,
We can
you mentioned it. I think it would be good still. Yeah.
So I think we have to keep her E2 low, and therefore probably let her keep the E2 low. We can use a progesterone prime stimulation or an antagonist protocol and give a agonist trigger. So this thing, that's what I said. And sometimes even if you're using the LNG IUD, you can just keep it in situ and just go ahead because it will maintain, it will keep the progesterone levels low. So this was a study which showed that it is a feasible and a safe strategy in patients of endometrial carcinoma. So it has also been shown that LNG has no negative impact on the cycle performance, including the total number of oocytes, mature oocytes, as well as the clinical pregnancy rate and the light weight rate. Is there a concern about relapse after COS? Because we are little bit of estrogen we are increasing. So because she's already attained she's already attained that it's the histopathology shown to be negative. So would the COS increase the incidence of relapse?
I think definitely a little bit of percentage increase will definitely be there. And I think that should be a part of a consent as well, that a little higher chance of recurrence, I think including it in the consent would be more wiser.
So the incidence is about 27%. And there was another paper in 18 which said that it's almost 50%, but on an average, it's anywhere between 20 to 30%. And especially it's lower in those who are using the LNG IUD, because then you're not stopping the progesterone. The LNG IUD is already there in the uterus, so it's having its effect, and therefore the COS is really not is going to make a lesser impact. And it will also depend upon the E2 levels on the day of HCG trigger, the duration of gonadotropin therapy, and the age and the time from treatment, and most reliable risk factors for the endometrial disease recurrence after a conservative treatment. So segmented IVF and frozen embryo transfer I think is a better option because you kept your LNG IUD, and this should then be removed after 2 months so that the effect of progesterone is there, and then probably you need to go for you can go for an FET cycle. And would you like, what type of a FET cycle would you like to do in this patient?
I would say natural cycle.
Mild stimulation with letrozole, madam. Letrozole and mild stimulation.
Yeah, but one could also try a natural cycle. No? So,
Yeah, I think natural cycle would be better.
yeah. So in case she does not, then you could
The
probably
modified natural cycle. Yeah.
You can go for an ovulation induction cycle, either with low gonadotropins or letrozole. So what about the luteal phase?
Up to 10 weeks, supplementing the progesterone has to be done.
Yeah.
Because it's a
I think progesterone will not, the luteal phase shouldn't matter. I think like how our normal pregnancy 8 to 10 weeks, I think we can go ahead and continue.
And then she can probably go. So this is what we have already asked, natural cycle. And basically, it's better not to go for an artificial cycle. So basically, and artificial cycle, as we know, have a higher risk of pregnancy complications, therefore should be avoided. So it has been seen that the live birth rate is about 26 to 28%. This thing, and it is much higher than the natural conception, the ART conception. It's almost 40% as against 15%. And therefore, there was another paper which also looked at grade 2 endometrial carcinomas who have achieved a complete remission and have also experienced a pregnancy rate. And so this was another paper in 2022, which have said that successful live birth is a protective factor for recurrence. So if she has a pregnancy, it is going to be a protective factor for the recurrence of the endometrial lesions, and different COS protocols and COS frequency, dosage and duration of gonadotrophins used did not affect the recurrence of the endometrial lesions. So how do you manage? Because many a times we have seen that there is a lot of endometrial damage. So how would you then improve the pregnancy aspects?
I think, yeah.
All those treatments that we give.
So therefore, one must avoid that. One must avoid a DNC and just do a hysteroscopy guided biopsy. And we should reduce the treatment duration, enhancing the treatment efficacy and minimizing the intrauterine procedures, which will decrease the endometrial damage, which is very, very important. And the potential treatment for thin endometrium could be, we should avoid high dose estrogen replacement, and probably we could try growth hormone aspirin, sildenafil to improve the perfusion, as well as the colony stimulating factor. But when you're using the PRP, colony stimulating factor, and as well as the stem cells, it's very important to keep in mind that these are all growth factors, and therefore they can increase the incidence of recurrence. The next question is, how would you prevent damage to reproductive organs in young men and women undergoing radiotherapy? What about scatter irradiation, and is there a role of radiotherapy in the management of endometrial carcinoma?
I think for young men, when we say young men, I'm not sure how young, but if it's somebody above 18, I think masturbate and freeze the semen would be a good choice, or even above 15 years, 14, 15 years. But if they're very young, then maybe testicular biopsy and the testicular tissue preserving is good enough. Yes, I think the radiation will definitely have a lot of problems to the pelvic radiation, especially. I think will be there.
I think if we give GnRH analog, Pardon?
No, it has no role. You can shield and
Yeah, shielding will be a better option.
That has to be done, but to some extent.
In all cases, male fertility, it is not indicated. In female, it is basically the evidence is there only for breast cancer patients, not for other cancers. But you can just reduce it because I think you didn't see my slide. There were no pregnancies when GnRH agonist was used in other malignancies. Though it reduced the complications of POI, but it did not result in any pregnancies.
I think more important with that this thing, agonist that we're using is, I think we all get referrals very late. We usually get it like they're posted tomorrow for surgery or another 2 days for surgery. So as such, the protocol should go on for almost start 2 weeks prior and continue for the next 4 weeks. I don't think we get referrals like we have 6 weeks time.
No. GnRH agonist is used only before and during chemo. So it's nothing to do with the surgery. So it's only,
No, I said even when Professor Sir said we have to use gonadotropins, and so I was telling
No,
we have to
not
use it for a longer
gonadotropins.
Duration.
Not gonadotropins.
Agonist. Yeah, so we none of us will get 2 weeks time. Nobody refers to us. I've almost got like 2 days in advance or 1 day only we get, and they say posted tomorrow for surgery, posted tomorrow for chemo or radio.
Make a difference, being honest.
Ovarian transposition now.
Yeah, transposition is also good.
So how would you prevent the scatter radiation?
Transposition. And here I think we can think about ovarian tissue cryopreservation.
Yeah, that is at the time of transposition you can do.
Yeah.
So along with that. So this I've already spoken in my talk that this was a study done a uterine transposition. And this is whatever we have discussed. Now going to the next case on breast cancer. So we know that the incidence is quite high. And the incidence of triple negative also require, those who triple negative require chemotherapy with alkylating agents. Whereas those which are ER/PR positive, basically what we give is tamoxifen. And the 5-year survival rate is as high as 75 to 91%. So basically after surgery, either you give chemo, you can give radio as well as hormonal therapy. And amenorrhea, which could be either temporary or permanent, and the collateral damage of chemotherapy can result in infertility, and this is basically age-related. So this was a patient who was 28 years, married for 1 year. Her menstrual cycles were regular. Her grandmother had breast cancer. There was a history of diabetes mellitus in the father. She had CA right breast, invasive ductal carcinoma, grade 2, ER/PR positive, HERS2 negative, and the stage was T2N0. BRCA mutation was not done. Surgery, wide excision, lumpectomy done. Post-surgery plan was tamoxifen plus radiotherapy. She's referred for fertility preservation. So how would you proceed? What fertility preservation options would you offer? And would you test for ovarian reserve and why?
Yeah, I think since she's already married and she has a history and she already has an invasive ductal CA, stimulation and embryo preservation is what I would say for her would be a better thing. And of course, before starting the stimulation, we better check her antral follicle count, AMH would all be a better choice.
Yeah, so because she's planned for radiotherapy, you need to go for fertility preservation. If she was given only tamoxifen and she's 28 years old and she's not given the Atlas therapy, then probably you could wait. You could wait and you could allow her pregnancy after she finishes tamoxifen. And so that would be the choice. And her ovarian reserve is important because even if she's 28 and only tamoxifen is going to be given, no radiotherapy, then also if her ovarian reserve is there, you can just wait. I mean, you need not do fertility preservation for this patient. So this we've already discussed that assessment is very, very important because it helps in predicting the ovarian response for a dose calculation as well as for counseling of the patient. So this patient had an AMH of 4.8, antral follicular count of 10 to 15 in either ovary. Her BMI was 20. So what protocol would you follow for COS and what would be your starting dose? Since the AMH and antral follicular count suggest PCOS, what preventive measure can we take to
Random start. We can go for random start protocol and with agonist trigger.
Letrozole can be also be given.
And
So it has to be because she's ER/PR positive. And antagonist, you could also give an antagonist. I mean, it has to be an antagonist protocol. And we should avoid PPOS because she's PR positive also. And what starting dose would you use in this patient?
250.
150.
150, I think it should be good
150
enough.
will be enough.
Pardon?
150 will
150,
be.
I think it should be good enough, ma'am.
Yeah, but this is the only chance now for her to preserve. So would you
But
like to?
she's PCO, so I think we can continue and step up later if required, but I think she should respond very well with 150, I guess so.
I'll go with 225 minimum.
I think 225 because we are giving letrozole to prevent and antagonist protocol. So we got 16 oocytes, 14 M2 and 9 day 3 embryos were cryopreserved. Any disadvantage of using letrozole? There are disadvantages. What are the disadvantages?
The number of oocyte may come down sometimes.
Mature oocytes.
That's a reason.
The M2, yeah, I think M2 will be a little lesser comparatively.
Yeah, so probably then in this case, you can give a trigger at 20 millimeters instead of 18 millimeters to have more follicles. So what about tamoxifen instead of letrozole? And moreover, letrozole increases the progesterone levels. And therefore, again, because she's PR positive, there could be increase in the proliferation of the tissue. So that also has to be kept in mind. It has been seen that letrozole always results in increase in the progesterone levels. And then, sorry. Is there any effect of COS and CA on the oocyte quality?
I think, yeah, quality will be a little lesser only comparatively.
Only if she's BRCA positive, no?
I think this lady was, no?
So only if she's BRCA positive, the quality of the oocytes as well as the number of oocytes are going to be less. But if she's BRCA negative, it really does not make a difference and there's no decrease in the ovarian reserve seen. And there was a study wherein when they looked at the BRCA positive in patients who are less than 35 and more than 35 years of age, with BRCA2, there was not much difference, but with BRCA1 mutations, there was definitely lesser AMH after the age of 35 as compared to those women lesser than 35. So basically it's letrozole which is going to affect the egg quality. So as I told you, lower yield and therefore basically you have to send and associated with the letrozole is associated, though it controls OHSS, your quality is basically affected because it impacts the microenvironment and the gene expression in the cumulus cells. And therefore, it has also been seen that there is a lot of altered morphology when letrozole is used in breast cancer patients who are undergoing fertility preservation. So it's a better option to use tamoxifen than to use letrozole because there are studies which have compared tamoxifen and letrozole for fertility preservation in patients who are ER/PR positive, and they have found that the cancer-free interval is almost similar, though it might be slightly higher for patients taking letrozole. But overall, the 5-year survival rate is almost similar. So therefore, tamoxifen probably is a better option. So this is what we've discussed. And this was again a paper which compared letrozole with tamoxifen, and it was a retrospective study. So they found that the number of oocytes retrieved, M2 oocytes, fertilization rate, duration of stimulation were almost similar in both the groups. But top quality embryo rate was lower in tamoxifen group in this study. And abnormal fertilization was higher in the letrozole group, as we already saw. And stepwise logistic regression analysis revealed that letrozole and peak E2 levels were significantly associated with abnormal fertilization. So if you had too low estrogen levels because of letrozole, the chances of having abnormal fertilization was much higher. So this patient, then the periods recovered in September at the age of 34 years. After 5 years of tamoxifen, she wanted to try for pregnancy. So she went for 2 cycles of ovulation induction with letrozole with IUI. Because the semen parameters were normal, the outcome was negative, returned for cryopreserved embryos. Monitoring was done, and in a natural cycle, they found that there was a polyp near the fundus. So this patient, do you think when she has cryopreserved embryo, she should go for ovulation induction with IUI? And because she also had a polyp, what would you do in this patient?
The polyp means definitely we have to remove it, but otherwise there is no harm in trying ovulation induction with letrozole and IUI, 1 or 2 cycles. But not to give a long trial because of the history. A short trial can be given, but if there is a polyp, definitely you have to go for it. Treatment.
But she has cryopreserved embryos, no?
Yes, but definitely no harm in trying with the ovulation induction. That option, you have to give the more chance of pregnancy we will be getting with the FET. That chance you have to give already. The costless part is over. So if the patient wants ovulation induction, we can give. Otherwise, we can definitely go for a FET cycle in this patient.
I think I would agree. I think if because the polyp is there, we have to go and remove the polyp. Even for us to try naturally or ovulation induction, we have to remember with the polyp, her conception is going to be very less. So once the polypectomy is done, either we can tell her to try naturally for 2-3 months, but not wait for too long, and maximum 2 cycles of ovulation induction. Because I think we need to respect the patient's decision as well. So
polyp has to be
and since
removed.
we've already preserved, I think our age shouldn't be a problem. I think there's nothing wrong in waiting.
We maybe need to do a biopsy.
And once we have already cryopreserved embryo, then I don't think there's, according to my opinion, we should have directly gone for the frozen embryo transfer cycle. And
No, whatever it may be, polyp has to be removed.
Biopsy, they could have endometrial cancer. Her BRCA is not tested.
Why has a polyp to be removed?
2 things. One, it decreases the chance of pregnancy. Second, we have to rule out any other hyperplasia in the...
It's a case of PCOS. So we know that the incidence of endometrial carcinoma is also
That's
higher.
what I told, hyperplasia.
Therefore, basically, we have to rule out endometrial carcinoma before we do the embryo transfer. And because she has several pathologies, it is better that we go in directly for a frozen embryo transfer rather than this thing. So FET, what type of cycle would you like to do in this patient?
Natural cycle.
PCOS patient, no?
Letrozole.
Modified natural cycle, I think, would be a better choice for her.
No, modified natural cycle is only giving HCG trigger. So it's
we will give her letrozole and letrozole with mild gonadotrophins. I think will be helping her.
I think it should be HRT cycle.
Why? By HRT cycle, you're giving estrogen and progesterone. Now, again, then you are affecting your CA breast because she's ER positive.
Letrozole.
Huh?
I think letrozole and gonadotropin mild stimulation.
Definitely, if the natural cycle of the endometrium comes up, we can try that. Otherwise, definitely mild stimulation with letrozole and gonadotropin.
Yeah, so natural cycle should be the first preference, and then probably that. So luteal phase support, because again she's ER/PR positive.
Definitely, I mean, if it is a
Vaginal
pardon.
vaginal progesterone.
So basically, that is why it is better to go for a natural cycle or a stimulated cycle, because then here you have the this thing of giving HCG for luteal phase support when you do a natural or a stimulated cycle. So you need not give progesterone for luteal phase support. What are the chances of spontaneous pregnancy after breast cancer? And if they conceive with tamoxifen, should we terminate this pregnancy?
I think that depends on what sort of post surgery treatment they had given, how far the initial ovarian reserve is. Both affects, and we have to wait usually for at least 1 year of after completion of the treatment and assess the ovarian status.
Anybody else has to say anything?
I think the chances of spontaneous pregnancy would be quite low. Because post chemo and radiotherapy, I think she will take at least minimum 2 to 3 years. And we would have assessed her AMH, antral follicle count. Maybe we'll have to wait for her to resume her cycles, then reassess her, and then it's a part of the counseling which we'll have to see.
No, but with tamoxifen, she's going to get her cycles. No?
I would say low.
Then can tamoxifen therapy be interrupted to plan a pregnancy before 5 years?
I think it's all about counseling, telling her since we are breaking her treatment, chances of...
No, there's evidence for it. Anybody knows? So we had the positive, so before that, yeah, so there is 70% lower after pregnancy, the chance of spontaneous pregnancy. And basically it's because of the decreased ovarian, a decreased ovarian reserve and general health. So this was the called as a positive trial, and wherein they stopped the tamoxifen after 2 years, allowed them to conceive on their own, and then they restarted the tamoxifen once she conceived. And what they found that there was no difference in the recurrence or the survival rates when it was when tamoxifen was deferred till she conceived and delivered, as compared to if she continued the tamoxifen. Therefore, probably this is very, very important. So do we want to continue or we stop here?
I think, ma'am, we can stop because it's nearly 7:30, and I think we can summarize and they have some take-home messages from all our panelists. And it was a very, very comprehensive coverage, ma'am, despite the extempore panel. And the panelists have also done a fantastic job. They pitched in, especially Lavanya was wonderful, and so was Pesi sir, and all the other panelists also.
Yeah,
so many panelists, I think they've backed out last minute because of the topic. So
yeah,
So madam, I want to add is that what last thing you asked about the whether we can interrupt. Now, what usually we do is that we get the clearance from the onco people. Then if they
that is the evidence now, Fesi, that's the positive trial which has been published. And they have looked at 800 and some patients, wherein after 2 years of therapy, they have stopped tamoxifen, allowed them to conceive spontaneously. And if they don't do so in 2 years' time, they've given 2 years' time for them to conceive, they start again. But if they conceive, then they are allowed to deliver, and post-delivery, they start the tamoxifen. And they have found that there's no difference in the recurrence rate or in the survival rate if it has been stopped intermittently after 2 years. And that is the positive trial which has been published.
I think it is good that we are having so many data these days and so many proven things. That also gives us the courage to counsel in this way, since we have a documented things. I think it is wonderful for foot
That is-
forward with
That is one
Madam.
thing I think we'll also discuss with our oncology people. And another thing is that what we have found is that if there is is to the ER positive patients, where most of the time they are reluctant to undergo the stimulation before any malignancy treatment, even if however we counsel. So that is one practical difficulty what we are seeing, because they will ask whether these drugs will have any effect. That is what practically what we have even what we and our gynec onco people has been finding is difficult.
Yeah, but therefore you're giving letrozole, you're keeping the levels low, and therefore really not going to affect the treatment. So basically that's the only way, and that is only if she is if she is older than 35 years of age, and she is going to then basically only with tamoxifen you need to do the fertility preservation. But if they're going to give adjuvant chemotherapy, or they're going to give chemotherapy before the surgery because of the stage of the disease, or they're going to give radiotherapy, then you have to go with oocyte embryo and embryo cryopreservation. Usually ovarian tissue cryopreservation should be avoided, because we know that there could be increased chance of ovarian malignancy in these patients. And all these patients should be tested for BRCA later, because then that is going to also tell us that how long, whether we should keep the ovaries or not. Because if BRCA is positive, it's best to do the oophorectomy in this group of patients. So, and also counsel for her to undergo a PGT to test for BRCA mutation before the embryo transfer is done, and also in her siblings. So
But I think before this, we have much more bigger hurdle where we don't get references on time. I think with all our knowledge of so much of treatment protocols, I think we have to urge our onco to do this on time.
No, madam, we get references from that, but when we combine counsel, if after the biopsy, if they simultaneously do the receptor test also, that's what I told. If it is positive, then whatever patients we did was all except one, all are negative patients, receptor negative. That's what I told. When the risk is explained, patients are not coming for the specific treatment. And another thing, what we for all CA breast patients, what we found is that when they are diagnosed before the surgery, usually few patients, what we had done is that we give the GnRH agonist, and after the surgery, then before the starting of the chemotherapy at that stage, we will be doing the stimulation. And so the chance of instead of random start protocol, if we give the long protocol in those patients, we will get time for before the surgery and get the more number of embryos.
There is no evidence for GnRH agonist long protocol at all in any malignancies. It has to be an antagonist protocol or a progesterone prime protocol, where giving progesterone doesn't make a difference, because if she's HER2 negative, she does all triple receptor negative, you can give PPS or you give antagonist, and it has to be a agonist trigger. There is no role at all for GnRH agonist long protocol in any malignancies. It has to be just an antagonist protocol.
Yeah, thank you so much, Madhuri ma'am. It was such a wonderful panel discussion, impromptu, and as always, it was just like a wow. Ma'am, I have one question. Like, मेरे जैसे बहुत सारे, there are so many gynecologists who want to do fertility preservation, and if we have any kind of doubt, how we can contact you, and
my number is there, you can contact me.
Ma'am, like, can we call you directly, or can we send you message, or can we mail so that we can?
I think mailing would be best, you know.
Yes.
You will, because
Madam is very good and prompt in responding to emails and checking her emails.
Yeah, ma'am. So we will contact you on mail, ma'am. So if anytime we have any kind of doubt in fertility preservation.
Yeah.
I have had the opportunity of listening to Madhuri ma'am whole of this month, and every session I have been just my level of awe for madam has gone up and up and up.
Nothing like
She,
that.
she can speak volumes on any topic, any topic. Madam, how much you must be reading every day? We can just imagine.
I don't read every day.
No, this is very, very inspiring for us, Madhuri ma'am, and we cannot thank you enough. You have taken our program to completion. Otherwise, our perfection series would have been imperfect today because
No,
of
no, Monica, Isar, Perfection series belong to Isar, and Madam is going to be president soon after a few years. So
Yes.
Isar has got the perfection in every post, every way.
Yes.
Sir, Randhir sir, I was about to say, Madam is the impersona of the perfection.
Yeah,
Yes.
no, we all together.
Encyclopedia, totally. Thank you so much, ma'am. And I think the topic is so huge that I think we need fertility preservation part 2 also.
Basically, I
And
also
I
want
think you should acknowledge Randhir sir so cutely. He's put Dr. Randhir Monica Singh.
Yeah. No, actually, the take-home message should be before we leave, as Madhuri ma'am told that we have to make our, as I think you only told, just you get a patient 2 days back before the surgery. So our aim should be, our oncologist should be timely.
all of you all can do CMEs wherever you want. I'm ready to come and we involve the oncologist, and we basically see that they are educated and then they start referring. So
Yeah.
I come anywhere to do the CMEs, and we are promoting. That is why these CMEs, and we are involving the oncologist. So that's a very important aspect of what FPSI is doing for this.
Thank
And Madhuri ma'am, malignancies are going very, it's not a very uncommon. Recently, I have my own family, so I know, ma'am, the malignancy is spreading a lot. So it is going to our old family members. So they should be properly, timely diagnosed.
Yeah.
No family is untouched by malignancy nowadays. What I see is no family is untouched, man. There is always.
That's what we eat. There's so much of pesticides in the food, what you are eating. If you're a non-veg, so much of hormones, the plastics, what are there, what we are using. So we should just totally avoid plastics. Plus, if you eat from outside, there's so much of chemicals which are put over there. And then ready-to-eat foods have so many chemicals to preserve them. So I think all this should be avoided. So it's a lifestyle first which has to change, because that's there. So we have a village near our place where they grow only capsicums, and they inject something to increase the yield. And that whole village has leukopenia. Not a single person has a count above 3,000.
Okay.
So
Yeah.
it's basically what we are eating. So nobody should eat grapes also. They should the maximum.
Yeah.
Ma'am, the ethics, I think, ma'am, nowadays the ethics have gone. The younger generation is, heading towards disaster, I feel. I don't
Yeah.
know what.
So I think again it will go to the nature. You have to go to Kashmir and Himalayas and all have natural fruits. Only that's all.
You can grow in your own house if you get to grow.
Yes, ma'am. Even if you have a patch, you have flower pots, we can grow. Enough vegetables for a small family can be grown. Yes, ma'am. Thank you so much, ma'am, Madhuri ma'am.
you, ma'am.
From the core of my heart, thank you so much, ma'am.
Thank
Thank
you,
you, Prasi sir, for please holding the fort for us right till the end as our, senior coordinator. Thank you, team INTAS. Thank you, Dr. Vishal, the medical man behind INTAS, for the tech support, the tech team. Thank you all panelists. Thank you all my coordinators, my MOCs. And till we meet again, our next fertility preservation is scheduled in April, in the month of April, and it will be totally dedicated to endoscopy. Thank you so much. And have a great day. Thank you. Thank you, Madhuri ma'am.
Bye.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Vishal, you're showing us a teaser of next time?
Yes.
Please do. We have a Marvel movie type teaser, Lavanya.
Okay.
Post, what's it called? Postscript, no? What's it called? After the movie, something comes, na? Children know what to call it. Manisha, क्या बोलते हैं उसको? Manisha has prepared for us. So symbiosis series coming up on 19th March, that is Tuesday, and we are doing it on endometriosis. We have got an international speaker, Professor Zheng from Taiwan. We have got Dr. Sujata Kar speaking. FOXI IAEC committee chairperson, Dr. Pratibha Singh will be deliberating. We invite you all to be a part of this webinar on 19th of March, 4 p.m. onwards. Thank you so much and have a great evening.
Thank you.
Bye. Bye.
Bye-bye. Bye.
Bye bye.
Bye.